Amenorrhea means no menstruation, and that's normal in females before puberty, during pregnancy and lactation, and after menopause. Now, for menstruation to happen, a female must have normal anatomy and a functioning hypothalamo-pituitary-ovarian axis. In other words, the hypothalamus must secrete gonadotropin-releasing hormone, or GnRH, to stimulate pituitary production of FSH and LH. And finally, the ovarian follicles must secrete estrogen and progesterone in response to FSH and LH stimulation. In childhood and early adolescence, estrogen leads to the development of secondary sex characteristics, like the development of breasts and the appearance of axillary and pubic hair. And eventually, usually 2 to 3 years after the breasts have started to develop, the first menstruation, or the menarche, occurs. Menstruation marks the beginning of the menstrual cycle, and that cycle repeats every 28 days on average, from puberty until menopause. Ovulation happens on day 14 of this average 28-day cycle. If the oocyte is fertilized by a sperm, then the remains of the follicle keep secreting estrogen and progesterone to help with the pregnancy until the placenta develops, and no menstrual bleeding occurs. In the absence of pregnancy, estrogen and progesterone levels gradually decrease, and when they get really low on day 28, this leads to menstruation and the beginning of a new cycle. So, physiology aside, primary amenorrhea is when a female has not begun breast development by age 13 and hasn't had menarche by age 15. Secondary amenorrhea is when a female started having menstrual periods, but then stopped having them. A pregnancy test is the first step for both primary and secondary amenorrhea, because some females can be pregnant even before they've had their first period. If the individual is not pregnant, then the next step for primary amenorrhea is staging a female's development using the Tanner scale. The Tanner scale centers on 2 criteria: the appearance of pubic hair, which is dependent on androgens, and breast development, which is dependent on ovarian estrogen. There are 5 stages. In stage 1, the prepubertal stage, no pubic hair is present, and females have a flat chest. In stage 2, soft pubic hair and breast buds appear. In stage 3, pubic hair becomes coarser and breast mounds form. In stage 4, pubic hair begins to cover the pubic area, and breast enlargement continues to form a mound-on-mound contour of the breast. Also, menarche usually occurs during Tanner stage 4. And finally, in stage 5, pubic hair extends to the inner thigh, and the breast takes on an adult contour. Next, a pelvic ultrasound should be performed to confirm the presence or absence of the uterus, and serum levels of FSH should be drawn. If there is a uterus and FSH levels come back high, that suggests gonadal dysgenesis, which is when the gonads don't develop properly in utero, and they're replaced by streak gonads, or functionless fibrous tissue, which can't respond to FSH stimulation, hence the high FSH levels. Also, since the streak gonads can't produce sex hormones, the individual doesn't have secondary female sex characteristics, like breast development. Causes of gonadal dysgenesis include Turner syndrome and 46XY gonadal dysgenesis, or Swyer syndrome. A karyotype helps distinguish the two. With Turner syndrome, roughly half of the individuals have a 45X karyotype, meaning they're missing one of their sex chromosomes. The other half of the individuals have a mosaic of either 45X and 46XX, or mosaic of 45X and 46XY. In the individuals with the mosaic genetic pattern, some of the cells in their body have a single X chromosome, while others have either 2 X's or an X and a Y. Individuals with Turner syndrome have a short stature, a wide or webbed neck, a broad chest with widely spaced nipples, low-set ears, as well as arms that turn outward at the elbows. Turner syndrome also has wide-ranging medical effects and requires a full workup of their various organ systems. Finally, in individuals with mosaic of 45X and 46XY cells, the presence of a Y chromosome carries a high risk of gonadoblastoma, so their streak gonads should be surgically removed. Individuals with Turner syndrome are given estrogen therapy in low doses that are gradually increased over 2 to 4 years to achieve normal pubertal growth and development. 2 years after estrogen is started, individuals should receive progesterone for 10 days a month to induce menstrual bleeding. Additionally, growth hormone therapy helps with short stature. Now, if the karyotype comes back 46XY, then they're a genetically male individual, even though they have female internal and external genitalia and streaked gonads. This can happen when a fetus has a Y chromosome, which contains a sex-determining region of the Y chromosome, or SRY, but doesn't have functioning gonads that can make testosterone or Müllerian inhibiting factor. Without the influence of these hormones, the fetus develops female internal and external organs and tissues. Like with Turner syndrome, the streaked gonads are at high risk of developing cancer, so they should be surgically removed. In addition, treatment relies on estrogen and progesterone therapy to induce cyclic menstrual bleeding. Finally, a rare cause of primary amenorrhea with high FSH levels is 17-alpha hydroxylase deficiency, an adrenal enzyme. This enzyme normally turns progesterone into 17-hydroxypregnenolone and 17-hydroxyprogesterone, which are then turned into cortisol and androgens. So, with the 17-alpha hydroxylase deficiency, there's low cortisol and androgens, which causes a lack of secondary sex characteristics. However, progesterone is shunted towards the adrenal aldosterone production pathway. This leads to a buildup of aldosterone precursors, like 11-deoxycorticosterone and corticosterone. Elevated levels of these weaker versions of aldosterone result in hypernatremia, hypokalemia, and hypertension. Lab work also shows high serum progesterone and deoxycorticosterone, and a serum 17-alpha hydroxyprogesterone below 0.2 nanograms per milliliter. Treatment relies on exogenous glucocorticoid replacement therapy with hydrocortisone and dexamethasone. Glucocorticoid replacement normalizes blood pressure, but that can sometimes take years. In the meantime, mineralocorticoid receptor blockade with spironolactone can help counter the effects of excess aldosterone precursors. Additionally, development of secondary sex characteristics can be induced with low-dose estrogen given during puberty, and a progestin can be added 2 years later to induce cyclic menstrual bleeding. Okay, now let's switch gears and see what the differential is for an individual that has a uterus, but their FSH levels come back low. First step is to repeat the FSH levels and also check the LH levels. If both are low, then the most likely cause is a hypothalamic or pituitary disorder, like congenital GnRH deficiency or constitutional delay of puberty. With congenital GnRH deficiency, the hypothalamus doesn't produce GnRH at all. One subtype is Kallmann syndrome, which is when the GnRH secreting neurons fail to form during fetal development. These neurons are closely linked to olfactory neurons, so individuals with Kallmann syndrome have absent, delayed, or incomplete puberty, as well as anosmia, or absent sense of smell. Normal adrenarche, however, still occurs, so these individuals do develop pubic hair. Constitutional delay of puberty, on the other hand, is when the individual just goes through puberty a little later, and it can be suspected if other females in the family also had a late menarche. Additionally, in this case, there's also no pubic hair development, because all features of puberty are delayed. The last clinical scenario is when the ultrasound reveals an anatomic abnormality, like evidence of an outflow tract obstruction or an absent uterus. Outflow tract obstruction can happen because of a transverse septum inside the vagina, or an imperforate hymen. On an ultrasound, there may be hematrometra, blood in the uterus, or hematocolpus, blood in the vagina. Individuals can have recurring menstrual cramps and pain without any outward signs of bleeding. Both of these can be corrected surgically. An imperforate hymen can be incised close to the hymenal ring, and then built-up blood can be evacuated. A transverse vaginal septum can be surgically excised. Alternatively, the ultrasound might show an absent uterus. 3 main causes of this are Müllerian agenesis, complete androgen insensitivity syndrome, and 5-alpha reductase deficiency. To differentiate these 3, we'll need a karyotype and serum testosterone levels. If the karyotype comes back 46XX, then the individual is genetically female, and the diagnosis is Müllerian agenesis. Individuals have a short vagina and either an absent or a rudimentary and obstructed uterus. But the ovaries develop normally in these individuals and produce normal amounts of estrogen and progesterone. So there's normal breast development and normal FSH levels and normal serum testosterone levels for a female. The diagnosis has major psychological implications, so psychological counseling is recommended. Some options are the surgical creation of a vagina, called a neovagina, and the use of vaginal dilators, which come in different sizes and work best when they're used a few times a week after a hot bath, when the vaginal tissue is relaxed. This can allow for a normal sex life. Also, since these individuals have functional ovaries, they can have children, either through assisted reproduction techniques like eggs harvested and in vitro fertilization, followed by a surrogate pregnancy. Alternatively, they can carry their own children if they undergo uterine transplantation. Now, the karyotype can come back 46XY, which means they either have complete androgen insensitivity syndrome or 5-alpha reductase deficiency. With androgen insensitivity syndrome, there's a defective androgen receptor, so even though their testosterone is in the normal male range, their tissues don't respond to it. They typically have female external genitalia, sparse body hair, little to no pubertal acne, and since some of that extra testosterone gets converted to estrogen, they also have well-developed breasts. These individuals have testes, which are normally located either in the abdomen, pelvis, or in the inguinal canal, so imaging studies should be done to identify them. However, body temperature is way too hot for the testes, so they have a high risk of developing testicular cancer. Therefore, they should be surgically removed, but only after puberty, to allow for development of secondary sex characteristics. Once again, psychological counseling, vaginal surgery, and vaginal dilation can be used to have a normal sex life. And finally, there is 5-alpha reductase deficiency, which is when people lack the enzyme 5-alpha reductase, which is required to convert testosterone into dihydrotestosterone, or DHT, which is a more potent metabolite. These individuals don't undergo DHT-dependent masculinization during fetal development. So at birth, they have either female or ambiguous external genitalia. At puberty, however, testosterone levels rise a lot, like they do in all males. So these individuals undergo virilization, meaning that they develop male pattern hair growth, acne, increased muscle mass, and a deeper voice. These individuals should get psychological counseling to discuss their gender identity. Some choose a male gender role and use DHT therapy, while others choose a female gender role and use estrogen therapy. Finally, there are various causes of secondary amenorrhea, and they can also cause primary amenorrhea. So on to secondary amenorrhea, which is diagnosed after 3 consecutive skip periods in females who previously had regular menstrual cycles, or after 6 months of no bleeding in females who previously had irregular cycles. Sometimes secondary amenorrhea can occur in the context of contraception. Females can experience amenorrhea while on birth control pills. It can also happen in females who stop taking oral contraceptives after taking them for a longer period of time. Additionally, up to 50% of females who wear a progestin-releasing intrauterine device may experience amenorrhea. Finally, initial lab studies include TSH, prolactin, as well as FSH and estradiol levels. And if there are signs of virilization, then testosterone levels should be checked as well. If TSH comes back high, then hypothyroidism is a cause of secondary amenorrhea. And treatment is thyroid hormone replacement therapy with levothyroxine. If serum prolactin levels are elevated, it should be rechecked just to make sure it wasn't transiently elevated due to stress. If both measurements are high, the diagnosis is hyperprolactinemia, which can be secondary to a prolactinoma, which is a benign tumor of the pituitary that secretes excess prolactin, or medications like antidepressants, methyldopa, risperidone, metoclopramide, cimetidine, and verapamil. If the individual is not on any of these drugs, then a head MRI should be performed to identify the prolactinoma. And if there is one, then it should be treated with cabergoline. Cabergoline is a dopamine agonist, and dopamine naturally inhibits prolactin secretion, so surgery is not required. If testosterone levels are above 60 nanograms per deciliter and there are signs of virilization, then that suggests polycystic ovarian syndrome, or PCOS. PCOS can cause oligomenorrhea, or amenorrhea, obesity, insulin resistance, and hyperandrogenism. If individuals are obese and have insulin resistance based on a 2-hour glucose tolerance test, then metformin therapy and weight loss are recommended. If there are signs of hyperandrogenism and the individual doesn't want to get pregnant, then they can be started on combined oral contraceptive pills, ideally a formulation containing a progestin with anti-androgen properties, like drospirenone. Alternatively, if oral contraceptives are contraindicated, spironolactone, an aldosterone receptor antagonist which has anti-androgen effects, can be used. If they desire pregnancy and have trouble conceiving even after metformin therapy and losing weight, ovulation can be induced with clomiphene citrate. Now, if androgen levels are really high, like above 150 nanograms per deciliter, then a CT scan of the abdomen and pelvis should be done to look for an androgen-secreting tumor of the ovary or adrenal glands. Okay, now if the TSH, prolactin, and androgen levels are normal, then secondary amenorrhea may be due to abnormal FSH and estradiol levels. High FSH with low serum estradiol in a female below age 40 who has additional symptoms like hot flashes and vaginal dryness suggests primary ovarian failure. That's where the ovarian follicles undergo accelerated atresia and get depleted before menopause. In these individuals, hormone replacement therapy with estrogen should be initiated to decrease the risk of osteoporosis and cardiovascular disease. In addition, progesterone should be given as well, so that there isn't unopposed estrogen, which is a risk for endometrial hyperplasia and cancer. If both FSH and serum estradiol are low, then the most common cause is functional hypothalamic amenorrhea, and that can be due to a systemic illness like type 1 diabetes mellitus and celiac disease. Alternatively, it can happen when there's a large tumor of the pituitary gland or central nervous system which compresses the FSH and LH secreting neurons, so a brain MRI should be done. Now, if all of the labs come back normal, then the uterus is not responding appropriately. For example, individuals might have intrauterine adhesions or Asherman syndrome. This is when there's scar tissue inside the uterine cavity, typically in a female who has undergone uterine instrumentation in the past, like dilation and curettage. To assess uterine function, a 10-day medroxyprogesterone test is done. That's where 10 milligrams of medroxyprogesterone is given daily for 10 days to see if that induces menstrual bleeding. A healthy uterus should bleed. If there's no bleeding, then estrogen is given for 35 days to thicken the uterine lining, and 10 milligrams of medroxyprogesterone per day is added from day 26 to day 35. Failure to bleed after that strongly suggests endometrial scarring. At that point, a hysterosalpingogram, which uses fluoroscopy with contrast to see the uterus and fallopian tubes, or direct visualization of the endometrial cavity with a hysteroscope, can be used to identify the intrauterine adhesions. Finally, if no cause is identified, then the diagnosis is probably functional hypothalamic amenorrhea. This can be suspected especially in training athletes who are over-exercising, or in individuals with eating disorders, nutritional deficiencies, or a body mass index below 18.5 kilograms per meter squared, as well as those who have been through some serious physical or emotional stress. Recommendations include lifestyle changes, like weight gain, and adequate caloric intake for the level of exercise. Psychotherapy can be useful in helping individuals cope with psychological stress. Alright, as a quick recap, the first step for both primary and secondary amenorrhea is to rule out pregnancy. Then, for primary amenorrhea, when the ultrasound shows a present uterus, high FSH levels indicate either gonadal dysgenesis or 17-alpha hydroxylase deficiency. Turner syndrome is a form of gonadal dysgenesis with a 45X karyotype, or mosaics of 45X and either 46XX or 46XY chromosomes. Swyer syndrome is gonadal dysgenesis with a 46XY karyotype. 17-alpha hydroxylase deficiency is confirmed by high serum progesterone and low serum 17-alpha progesterone levels. A present uterus, but low FSH and LH levels indicate either GnRH deficiency or constitutional delay of puberty. If the ultrasound shows blood in the uterus or vagina, an outflow tract obstruction is suspected. Now, if there is no uterus, then a karyotype and serum testosterone levels should be obtained. Individuals with Müllerian agenesis have a 46XX karyotype and serum testosterone in the normal female range. Individuals with a 46XY karyotype and testosterone in the normal male range have either complete androgen insensitivity or 5-alpha reductase deficiency. Finally, all causes of secondary amenorrhea can also present as primary amenorrhea. These include hypothyroidism, hyperprolactinemia, and androgen excess, like with polycystic ovarian syndrome. If neither one of these is the case, then high serum FSH and low serum estradiol can diagnose primary ovarian insufficiency. If both FSH and serum estradiol are low, there is a hypothalamic or pituitary issue in the context of systemic illness like diabetes mellitus type 1 or celiac disease, or large tumors of the pituitary or the central nervous system. If all labs come back normal, and there's no menstrual bleeding following a progestin or estrogen-progestin challenge, then secondary amenorrhea is due to intrauterine adhesions. Finally, when none of these is the cause, then functional hypothalamic amenorrhea can be suspected.
Amenorrhea means no menstruation. It's normally before puberty, during pregnancy and lactation, and after menopause. Sometimes, though, menstruation either never starts, which is called primary amenorrhea, or suddenly stops in a person who's previously menstruating, which is called secondary amenorrhea. Now, menstruation and the menstrual cycle as a whole are controlled by the hypothalamus and the pituitary gland, all the way up in the brain. The hypothalamus secretes gonadotropin-releasing hormone, or GnRH, which makes the nearby anterior pituitary gland release follicle-stimulating hormone, or FSH, and luteinizing hormone, or LH. In the first 2 weeks of an average 28-day cycle, the ovaries go through the follicular phase, meaning that out of the many follicles scattered throughout the ovaries, a couple of them enter a race to become the dominant follicle that will be released at ovulation. All the developing follicles secrete loads of estrogen, which negatively inhibits pituitary FSH. In the meantime, the uterus goes through 2 phases, the menstrual and the proliferative phase. During the menstrual phase, the functional layer of the endometrium is shed and eliminated through the vagina, leading to menstruation, which lasts an average of 5 days. It's followed by the proliferative phase, during which the rising levels of ovarian estrogen make the functional layer of the endometrium thicken and sprout endometrial glands. Additionally, spiral arteries emerge to nourish the growing functional endometrium. After ovulation, the ovaries enter the luteal phase, which lasts for the 2 weeks following ovulation. During the luteal phase, the remnant of the ovarian follicle, called the corpus luteum, makes progesterone, which negatively inhibits pituitary LH. Progesterone makes the endometrium go through the secretory phase, during which it thickens some more, and spiral arteries continue to grow. If the egg is not fertilized by a sperm, estrogen and progesterone levels slowly decrease. When progesterone reaches its lowest level, the spiral arteries collapse, and the functional layer dies off and is eliminated through menstruation, which marks the beginning of a new menstrual cycle. Okay, now coming back to amenorrhea. Primary amenorrhea is when a female hasn't had her first menstruation, called menarche, by age 16, despite normal growth and having started puberty. Primary amenorrhea is also suspected when a female hasn't had menarche by age 13 and doesn't show signs of puberty, which include developing secondary sexual characteristics like breasts. The most common cause of primary amenorrhea is Turner syndrome, where one X chromosome is either completely or partially absent. The most common karyotype is 45X, which means the person has 45 chromosomes, of which only one is an X chromosome. With Turner syndrome, the ovaries are replaced by streaked gonads, or functionless fibrous tissue. This happens because the missing X chromosome leads to accelerated ovarian follicle depletion, so that by 2 years old, none are left, essentially causing menopause before menarche. No ovarian follicles also means no estrogen and progesterone, which leads to high levels of FSH and LH. The second most common cause of primary amenorrhea is Mullerian agenesis, which is also called Meyer-Rokitansky-Kester-Hauser syndrome. In this case, the Mullerian duct system doesn't develop properly in a biologically female fetus. The Mullerian duct system is responsible for the development of the uterus, cervix, and upper 2/3 of the vagina, so these organs may be absent or rudimentary and obstructed, which explains the absence of menses. But the ovaries develop normally in these individuals, and the ovarian follicles make normal amounts of estrogen and progesterone, so there are normal levels of FSH and LH. A rarer cause of primary amenorrhea is androgen insensitivity syndrome. In this case, the individual is biologically male, which means they have a 46XY karyotype, but their androgen receptors don't respond to testosterone. So they don't have a uterus, fallopian tubes, or ovaries, which explains the absence of menses. But they have testicles, which are usually in the abdomen or inguinal canal, and they make up the normal amount of testosterone for a biologically male individual, so FSH and LH levels are normal. Some of that testosterone gets converted into estrogen, so these people have female external genitalia and female secondary sex characteristics. Finally, endocrine disorders can also cause primary amenorrhea. These include Kallmann syndrome, where GnRH-producing neurons fail to migrate from the nose region to the hypothalamus during fetal development. This causes low levels of GnRH, FSH, and LH, and, as a consequence, low estrogen, so puberty either never starts or is incomplete. Okay, now let's switch gears and look at causes of secondary amenorrhea, which is defined as no menstrual bleeding for at least 3 normal menstrual cycles in a female who previously had regular cycles, or for 6 months for females who used to have irregular cycles. There are many causes of secondary amenorrhea, and when they occur before menarche, all of these can also cause primary amenorrhea. The most common cause of secondary amenorrhea is pregnancy. Next, there's functional hypothalamic amenorrhea, which is when there's a decrease in GnRH secretion, leading to low levels of LH, FSH, and estrogen. Often, this is due to weight loss from anorexia, nutritional deficiencies like excessively low fat consumption, prolonged periods of strenuous exercise, or severe physical or emotional stress. Another condition that affects the hypothalamic pituitary ovarian axis and can be responsible for secondary amenorrhea is polycystic ovary syndrome. Now, it's not clear exactly what causes PCOS, but there seems to be an imbalance between LH and FSH levels. Specifically, ovulation doesn't occur, so progesterone levels don't rise enough to inhibit LH production. This leads to an increase in the production of LH compared to FSH, so there's an elevated LH to FSH ratio. Additionally, because there's post-ovulatory rise and fall in progesterone, there's no menstruation. Issues with the pituitary gland can also cause secondary amenorrhea. One cause is hyperprolactinemia, or excessive prolactin secretion by pituitary lactotroph cells, which is frequently seen with a benign pituitary tumor called a prolactinoma. High prolactin levels inhibit hypothalamic GnRH production, which inhibits ovulation and menstruation. Interestingly, hypothyroidism, a condition where there's low levels of thyroid hormones, can also cause amenorrhea. This is because low thyroid hormone levels tell the hypothalamus to release more thyrotropin-releasing hormone, or TRH, and tell the pituitary to release more thyroid-stimulating hormone, or TSH. When this happens, TRH also stimulates prolactin release, so hyperprolactinemia and amenorrhea occur. Now, sometimes, secondary amenorrhea can occur because of premature ovarian failure, which is when the ovarian follicles undergo accelerated atresia and get depleted before the age of 40, resulting in early menopause. This leads to low serum estrogen and high FSH and LH. Finally, a structural cause of secondary amenorrhea is intrauterine adhesions, or Asherman syndrome, which is when there's scar tissue inside the uterine cavity, typically in a female that's undergone uterine instrumentation in the past. Amenorrhea can occur because there's so much scar tissue that there's no functional endometrium left, or because the presence of scar tissue makes the endometrium refractory to hormonal stimulation. The one symptom of both primary and secondary amenorrhea is, well, the absence of menstruation. Additional symptoms depend on the cause. Individuals with Turner syndrome have a short stature, absent secondary sex characteristics, and a wide or webbed neck. Mullerian agenesis might cause dyspareunia, or painful sexual intercourse, and infertility. With androgen insensitivity syndrome, individuals typically have sparse body hair and little to no pubertal acne. With Kallmann syndrome, there may be anosmia, or absent sense of smell, because the neurons responsible for olfaction are closely related to the ones that release GnRH. With functional hypothalamic amenorrhea due to anorexia, there's significant weight loss and decreased bone density, which can cause fractures. With polycystic ovary syndrome, the ovarian follicles secrete too much testosterone, causing hirsutism, or excessive hair growth on the chin and upper lip, chest, and back. With a prolactinoma, there might be galactorrhea, or abnormal milk production. With premature ovarian failure, there may be additional symptoms like hot flashes or vaginal dryness. With intrauterine adhesions, there could be infertility. The first step in diagnosing primary or secondary amenorrhea is to rule out pregnancy with a pregnancy test. If that's negative, diagnosis requires serum levels of FSH, LH, estrogen, prolactin, TSH, and testosterone. A karyotype can be done for Turner syndrome and androgen insensitivity syndrome. An ultrasound can show if there are structural issues with the vagina and the uterus, which suggests Mullerian agenesis, or if there's no uterus and intra-abdominal testicles are found, that suggests androgen insensitivity syndrome. Intrauterine adhesions can be visualized through hysteroscopy. Treatment depends on the underlying condition. Hormone replacement therapy, like combined oral contraceptives, can be useful for individuals with Turner syndrome, polycystic ovarian syndrome, or premature ovarian failure. For a prolactinoma, dopamine agonists like cabergoline can be used because they inhibit prolactin secretion just like dopamine naturally would, and they shrink the adenoma. Surgery can be used to remove intrauterine adhesions and to help correct some of the structural issues in Mullerian agenesis. In some cases, psychotherapy can also be useful, as well as treatment for the related fertility issues. Alright, as a quick recap, amenorrhea is the abnormal absence of menstruation in females of reproductive age. It can be primary, in which menstruation never started, or secondary, in which case regular menstruation has stopped in a female who was previously menstruating. Causes of primary amenorrhea include Turner syndrome, Mullerian agenesis, androgen insensitivity syndrome, and endocrine disorders like Kallmann syndrome. Causes of secondary amenorrhea can also cause primary amenorrhea, and they include functional hypothalamic amenorrhea, polycystic ovary syndrome, hyperprolactinemia, premature ovarian failure, and Asherman syndrome. Other associated symptoms, serum FSH, LH, estrogen, and testosterone, as well as an ultrasound or a karyotype, can be used to identify the underlying condition.
Breast cancer, or breast carcinoma, is an uncontrolled growth of epithelial cells within the breast. It's the most common cancer in women, but can rarely affect men as well. Now, estrogen and progesterone stimulate breast cells to grow and divide, and exposure to them over long periods of time increases the risk of breast cancer. More menstrual cycles over a lifetime means a higher cumulative exposure to these hormones. That's why factors that increase the number of menstrual cycles increases the risk of breast cancer. That includes things like early menarche, or a first menstrual bleeding before 11 years of age, and late menopause, after 54 years of age. On the flip side, some factors that are associated with fewer lifetime menstrual cycles, like pregnancy and a longer time breastfeeding, decrease the risk of breast cancer. Similarly, hormone replacement therapy used to treat menopause symptoms also increases that risk. Another risk factor is exposure to ionizing radiation, like from chest x-rays and CT scans or previous radiation therapy for other cancers located in the chest. Breast cancer has been linked to mutations in tumor suppressor genes, like BRCA1, BRCA2, and TP53, which normally prevent uncontrolled cell division. Some breast cancers have mutations in the ERBB2 gene, which causes an increase in human epidermal growth factor receptor 2, or HER2, which promotes cell division. Finally, some breast cancer cells have estrogen or ER receptors and progesterone or PR receptors, which allow them to divide faster in the presence of these hormones. Breast cancer is the second leading cause of cancer deaths in women after lung cancer, and this is largely due to the fact that breast cancers often don't cause pain or discomfort until they've metastasized. Now, breast self-examination isn't recommended for screening purposes, because it has not been shown an overall benefit. In fact, it's led to a higher rate of breast biopsies that shows benign disease, and leads to some women doing it instead of mammography. Nevertheless, some women who feel safer doing a breast self-exam should learn the proper technique. The best time for breast self-exam is during the week after menstruation ends, or any time of the month for postmenopausal women. The first thing to do is stand in front of a mirror and check the breast for any changes in skin color or texture, dents, and the appearance of the nipples, as well as signs of breast asymmetry. Next, the woman should lie down and use one hand to examine the breast on the opposite side, starting in the upper breast near the armpit and going up and down, and slowly moving across the breast. Using the 3 middle fingers, she should make small circles to feel into the breast. Once one side is done, she should change hands and feel the other breast. In breast cancer, there's often a single, hard, immovable lump with irregular borders. Other characteristic signs of breast cancer include skin retraction and ulceration, or an inverted nipple. Now, in the general population, the recommendation is mammography screening for women over age 40. For women between 40 to 49 years, the screening frequency is variable, with some recommending annual screening to identify aggressive breast cancers that can occur in this age group. Women aged 50 to 74 should get mammographic screening once every 2 years, and women older than 75 years should continue screening only if their life expectancy is over 10 years. If mammographic screening identifies an abnormality, then the next step is supplemental mammographic views, or an ultrasound. Now, for high-risk women, meaning those who have a BRCA gene mutation or other susceptibility genes, or women with a history of chest radiation, should have an annual screening breast MRI. If they can't have an MRI, then a screening ultrasound is recommended. These women still get annual mammography, so they effectively get one screening test every 6 months. Once a cancer-causing mutation does happen, the affected cell, which is most commonly an epithelial cell that lines the ducts or the lobules, begins to grow and replicate out of control, forming a tumor. This tumor, also called in situ carcinoma, is initially localized within the basement membrane of the alveoli, and can be of 2 types. The most common type is ductal carcinoma, which starts as ductal carcinoma in situ, or DCIS. And that's where tumor cells grow from the walls of the ducts into the lumen. DCIS often has calcifications, which can be spotted on mammography. If left untreated, DCIS over time can often cross the basement membrane to become invasive ductal carcinoma. Then there's lobular carcinoma, which again starts as lobular carcinoma in situ, or LCIS. And that's where clusters of tumor cells grow within the lobules, without invading the ducts, causing the affected alveoli to enlarge. Unlike DCIS though, LCIS rarely crosses the basement membrane to form invasive lobular carcinoma. Also, unlike DCIS, LCIS rarely has calcifications, so it's not recognizable by mammography, but it is recognized with ultrasound. A rare and aggressive form of breast cancer is inflammatory breast cancer, which happens when malignant cells block the lymph nodes in the skin of the breast. Inflammatory breast cancer is different from other forms of breast cancer because it usually doesn't cause a lump or mass, so it's particularly tricky to diagnose. Initial symptoms include itching, pain, swelling, nipple inversion, warmth and redness throughout the breast, and peau d'orange, which is when the skin has the appearance and dimpled texture of an orange peel due to cutaneous lymphatic edema. The signs of more advanced disease include axillary lymphadenopathy, as well as Paget's disease of the breast, which causes skin changes like redness, discoloration, and mild flaking of the nipple skin, resembling eczema. As Paget's disease of the breast advances, symptoms include tingling, itching, increased sensitivity, burning, pain, and even bloody discharge from the nipple. Any of these symptoms should trigger mammography and breast ultrasound, and the preferred modality depends on the breast consistency, which is largely determined by a woman's age. In women over 30, mammography is the preferred first imaging technique. Mammography shows tumors that have calcifications, and key findings are spiculated soft tissue masses and microcalcifications. Unfortunately, there are some tumors that don't have calcifications, called mammographically occult disease. And there are also some aggressive cancers that develop quickly between mammograms called interval cancers. In women under 30, a breast ultrasound is the preferred first imaging technique. The ultrasound helps differentiate between solid and cystic breast masses. If the ultrasound is indeterminate, mammography is often performed, although it's less effective in young women. Now, regardless of imaging results, all palpable breast lumps must get their cytology and histology done to confirm the diagnosis. In addition, lymph node involvement must always be assessed with lymph node biopsy. Cytology is done through fine needle aspiration, or FNA, where fluid from the lump and suspicious lymph nodes is taken under ultrasound or mammographic guidance. The visual appearance of individual cells helps identify their proliferation rate and malignancy potential. Histology is done with a core biopsy, where a needle is used to obtain a sample from the lump. Generally, a percutaneous palpation-guided or imaging-guided biopsy is done. If that's not feasible, then a surgical biopsy can be done. Histologic testing for ER and PR expression, as well as for overexpression of human epidermal growth factor 2 or HER2 receptors is done. Based on that, breast cancers are divided into 3 major types: HER2 negative and ER and PR positive carcinoma, which is the most common, HER2 positive and ER and PR positive or negative carcinoma, and HER2 negative and ER and PR negative carcinoma, called triple negative breast cancer. Additionally, an MRI can be done, which is particularly helpful in females with breast prosthesis. Nearly all invasive breast cancers enhance on gadolinium contrast enhanced MRI, even ones that are not evident on physical examination, mammogram, or ultrasound. MRI findings include irregular or spiculated margins, rim enhancement, heterogeneous internal enhancement, and enhancing internal septa. The most common sites of breast cancer metastasis are the bone, lungs, and liver. Individuals with bone pain or an elevated alkaline phosphatase should get a bone scan. If the bone scan is negative, and if there's a persistent concern, then an MRI of the concerning region should be done. For individuals with respiratory symptoms, a chest X-ray or chest CT can be done to look for lung metastases. For individuals with elevated transaminases, or an elevated alkaline phosphatase, or abdominal pain, a CT scan of the abdomen and pelvis should be done. Finally, in individuals with numerous symptoms, a whole-body PET CT should be done. After the workup is complete, breast cancer is staged using the TNM system. T indicates the size of the tumor and whether or not it has grown into nearby areas, for example, the chest wall muscles. N describes the degree to which the cancer has spread to nearby lymph nodes, particularly the axillary lymph nodes. The internal mammary or supraclavicular nodes might also be involved at the initial presentation, but they rarely occur in the absence of axillary node involvement. And finally, M indicates the presence of distant metastases. Each of these categories is ranked from 0 to 4, with 4 being the most severe. The TNM system classification determines the stage of the breast cancer, where the stage is between 0 to 4. Stage 0 is a precancerous or an in situ disease, meaning that the tumor has not invaded beyond the basement membrane. Stages 1, 2, and 3 are non-metastatic breast cancer. Early stage breast cancer includes individuals with stage 1, 2A, or stage 2B disease that's T2N1. Locally advanced breast cancer includes stage 2B disease that's T3N0, as well as stage 3 disease. Finally, stage 4 is metastatic breast cancer. Treatment for breast cancer is based on the type, stage, and pattern of receptors that are expressed. Surgery is the mainstay of treatment whenever possible, and is followed by other treatments like radiation, chemotherapy, endocrine therapy, and targeted therapy towards specific receptors expressed by the tumor cells. Medications used after surgery are called adjuvant therapy, whereas medications used prior to surgery are called neoadjuvant therapy. The surgical approach to the primary tumor depends on the size of the tumor, the size of the breast, and whether the disease is multifocal, meaning it has more than one location. In breast-conserving surgery, only the affected area is removed and adjuvant radiotherapy is given to destroy tumor cells that might have escaped the surgery. In a mastectomy, the whole breast is removed, either with or without adjuvant radiotherapy. Nearby lymph nodes should be removed if the cancer has metastasized to them. If the preoperative lymph node biopsy is positive, an axillary node dissection should be performed. On the other hand, if the lymph node biopsy is negative, a sentinel lymph node biopsy at the time of surgery should be performed. Individuals with fewer than 3 pathologically involved sentinel nodes might not require an axillary node dissection, while individuals with 3 or more pathologically involved sentinel nodes may undergo an axillary node dissection determined on an individualized basis, taking into account all other tumor risk factors and the individual's performance status and comorbidities. In some cases, adjuvant radiotherapy is given at the time of surgery. Radiotherapy can be given as external beam radiotherapy, where an external source of ionizing radiation is pointed at the particular part affected to send radiation to the tumor or involve lymph nodes from outside the body. Alternatively, brachytherapy is given, which is internal radiotherapy where a sealed radiation source is placed directly inside or next to the area requiring treatment. Following surgery, some individuals might get adjuvant therapy. Indicators of high risk of tumor recurrence include high-grade tumor, large tumor size, larger than 2 centimeters, or pathologically involved lymph nodes. Premenopausal women with ER-positive low-risk breast cancer can be given tamoxifen as adjuvant therapy. Tamoxifen can cause congenital anomalies during pregnancy, so women must be on some form of contraception, and should wait for at least 2 months after discontinuing tamoxifen before attempting pregnancy. Premenopausal women with high-risk breast cancer should get exemestane as adjuvant therapy, as well as surgery or medications like leuprolide or goserelin used to cause ovarian suppression to prevent the ovaries from making estrogen. On the other hand, postmenopausal women with ER-positive breast cancer should get an aromatase inhibitor, like exemestane, anastrozole, and letrozole, as adjuvant therapy. HER2-positive breast cancer gets treated with trastuzumab, alone or in combination with chemotherapy if the tumor is bigger than 1 centimeter. Finally, triple-negative breast cancer that's bigger than 0.5 centimeters generally gets adjuvant chemotherapy after surgery. One of the most common regimens is called AC, and it combines cyclophosphamide with doxorubicin. Sometimes a taxane drug, like docetaxel, is added, and the regimen is then called CAT. Another common treatment is cyclophosphamide, methotrexate, and fluorouracil, and that's called CMF. Most individuals with advanced, inoperable breast cancer should get neoadjuvant systemic therapy, and then have the cancer restaged to see if it's resectable. Most individuals who need neoadjuvant therapy get chemotherapy, since it's associated with higher response rates in a faster time frame than endocrine therapy. For tumors that are HER2 positive, trastuzumab should be added to the chemotherapy regimen. Metastatic breast cancer is unlikely to be cured, So individuals with hormone receptor positive disease are initially treated with targeted therapy, which are generally less toxic than chemotherapy. If individuals have had tumor progression despite being on multiple endocrine medications, then chemotherapy is tried. If the metastatic breast cancer is triple-negative metastatic disease, then chemotherapy is used right away. Some cases might get local treatments, like surgery or radiation, to help prevent or treat symptoms or complications from the cancer. But these treatments are not curative. Alright, as a quick recap. Breast cancer is associated with increased exposure to estrogen, which can be due to risk factors like early menarche, late menopause, and medications containing estrogen. Breast cancer has also been linked to gene mutations like BRCA1 and BRCA2, and TP53. Some breast cancers also have increased expression of the receptors HER2, ER, or PR. Breast cancer generally presents as a hard, immovable, single dominant lump with irregular borders. Other signs are skin retraction and ulceration, an inverted nipple, peau d'orange, bloody discharge from the nipple, and axillary lymphadenopathy. Mammography is first line for imaging women over 30, and ultrasound is first line for women below 30, and both of these can be used to guide biopsy, which can confirm the diagnosis. In some cases, further imaging with an MRI, CT scan, or PET-CT scan might be needed. Screening programs involve mammography, and are generally done in women over 50. The first treatment for breast cancer is surgery, which is divided into breast-conserving surgery plus radiation therapy, or mastectomy, either with or without radiation therapy. In addition, nearby structures like lymph nodes might be removed if the cancer has metastasized to them. The most common chemotherapy regimens are AC, CAT, or CMF. Endocrine therapy includes tamoxifen, exemestane, or an aromatase inhibitor for ER-positive breast cancer, while targeted therapy involves trastuzumab for HER2-positive breast cancer. Metastatic cancer cannot be cured, but might be treated with systemic therapy, either endocrine therapy or chemotherapy, as well as local treatments like surgery or radiation to help prevent or treat symptoms in some cases. "64-year-old Cassie comes into the office because of a new breast mass that she found on her monthly self-examination. A mammogram shows microcalcification clusters, so an excisional biopsy is performed. Pathology shows high-grade cells with central necrosis in the lumen and dystrophic calcification in the center of the ducts without invasion of the basement membrane. Later that day, a 58-year-old named Linda comes to the physician's office with eczematous dermatitis of the left nipple and areolar area for the past 24 months. Her history reveals that the lesion's been treated unsuccessfully with topical steroids and has progressively distorted the nipple, resulting in nipple inversion. Physical examination reveals scaly, crusted, and deformed left nipple with multiple plaques overlying the surrounding areola. At first glance, you'd think Cassie and Linda have nothing in common. But the fact is, they have different forms of breast cancer. Breast cancer is the most common malignancy in women, and it's typically seen in postmenopausal women, over 50 years of age. Most breast cancers are adenocarcinomas, and they typically arise from the terminal duct lobular units. Breast cancer can present as a palpable hard mass, most commonly located in the upper outer quadrant of the breast. Now, some breast cancers can be associated with amplification and overexpression of genes for estrogen receptors, progesterone receptors, and HER2 new receptors. For your exam, you have to remember that these receptors are important for therapeutic and prognostic factors of breast cancer. In other words, breast cancers that are associated with overexpression of estrogen and progesterone receptors are more susceptible to anti-estrogen medications, like tamoxifen. On the other hand, HER2 new receptors, also known as ERB-B2 receptors, are coded by the ERB-B2 gene. These receptors are transmembrane glycoproteins with tyrosine kinase activity that plays an important role in epithelial growth and differentiation. HER2 new receptors are present in small amounts in normal breast and ovarian cells, while they're overexpressed in 25 to 30% of breast cancers, as well as in adenocarcinomas of the ovary, lung, stomach, and salivary glands. Moreover, breast cancers that are associated with HER2 new positivity are linked to more aggressive tumors. However, they're more likely to respond to anti-HER2 monoclonal antibodies, like trastuzumab. Another high-yield fact is that breast cancers that are estrogen negative, progesterone negative, and HER2 neu negative, or in other words, triple negative, are linked to a more aggressive form of breast cancer. Finally, breast cancers tend to metastasize first to the axillary lymph nodes, while in the later stages, the most common sites of metastases include the lungs, liver, and bones. Now, switching gears and moving on to risk factors. The most common risk factors in females include advanced age and family history of breast cancer, which is considered the strongest risk factor. The risk of hereditary breast cancer is increased even more in young women who have had more than one close relative with premenopausal breast cancer. Also, a family history of ovarian cancer is linked to an increased risk for ovarian and breast cancer, because both of these cancers are associated with autosomal dominant mutations of BRCA1 and BRCA2 genes. BRCA genes code for BRCA proteins that act as a tumor suppressor that controls the cell cycle, helps repair DNA, and regulates transcription of DNA. Moreover, women with the BRCA1 mutation have a 70 to 80% higher risk for developing breast cancer, and a 40% increased risk for developing ovarian cancer compared to women without the BRCA1 mutation. Another commonly high-yield factor on your exam is increased estrogen exposure, like nulliparity, late first pregnancy, early menarche, and late menopause. Other risk factors include alcohol consumption, absence of breastfeeding, and obesity in postmenopausal women. Remember that after menopause, estrogen levels typically drop, but adipose tissue converts androstenedione to estrone, which is a weak estrogen. Finally, you shouldn't forget the influence of race in breast cancer. Caucasians are at the highest risk, while people of African descent are at increased risk for development of triple-negative breast cancer. Alternatively, risk factors for breast cancer in men include BRCA2 mutation and Klinefelter syndrome. In terms of screening and diagnosis, according to the American Cancer Society guidelines, women aged 45 to 54 years should also undergo screening mammography every year. If a breast mass is palpated during physical exam, a woman should undergo mammography, which is the initial imaging technique used for palpable breast lesions in women older than 35 years. Clinicians can also use needle biopsy to evaluate suspicious breast lesions, since this is the most specific diagnostic tool. As far as the treatment goes, breast cancer is treated with surgery, radiation therapy, and systemic therapy. Surgical management of breast cancer can be performed as a radical mastectomy, which stands for removal of one or both breasts, or breast conserving, which stands for removal of cancerous tissue while avoiding mastectomy. Chemotherapy agents include trastuzumab, a monoclonal antibody against HER2 neu receptors, and tamoxifen, which is a selective estrogen receptor modulator. Finally, aromatase inhibitors like anastrozole can also be used to treat estrogen receptor-positive breast cancers in postmenopausal individuals. Now, breast cancer can be subdivided into non-invasive and invasive breast cancers. First, let's start with non-invasive breast cancers. Now, remember that at the time when they're found, they have not crossed the basement membrane and invaded other tissue. These include ductal carcinoma in situ, Paget disease of the breast, and lobular carcinoma in situ. Ductal carcinoma in situ, or DCIS, is a precancerous lesion characterized by a mass of neoplastic cells that arise from epithelial cells in the terminal duct lobular unit. As they proliferate, neoplastic cells fill the lumen of the duct, but at the same time, they do not invade into the basement membrane, which is why they're in situ. In most cases, DCIS affects only one ductal system, but in some individuals, it can present as a more extensive lesion that spreads to surrounding breast tissue. In addition, DCIS accounts for 15 to 30% of all carcinomas found on screening mammograms, and 50% of all carcinomas identified on diagnostic mammograms. Now, there are two subtypes of ductal carcinoma in situ: comedo-DCIS and non-comedo-DCIS. Comedo-DCIS, also referred to as comedocarcinoma, is associated with solid sheets of pleomorphic, high-grade malignant cells, which indicate that the cancer is growing rapidly. Moreover, central malignant cells can die and result in central necrosis, which can eventually calcify and form dystrophic calcifications. Additional findings can include chronic inflammation and periductal concentric fibrosis. Finally, if left untreated, malignant cells can eventually penetrate the basement membrane and invade the surrounding breast tissue, forming a poorly defined palpable breast nodule. So for your exam, you have to remember that comedocarcinoma typically does not produce a mass lesion, unless it has invaded the surrounding breast tissue. Instead, it's most commonly identified as microcalcification clusters on mammography. In contrast to comedo-DCIS, non-comedo-DCIS is not associated with central necrosis, and it's subdivided into 3 types: papillary and micropapillary DCIS, which are characterized by malignant cells that are arranged in a finger-like pattern within the duct; cribriform DCIS, which is characterized by gaps between malignant cells; and solid DCIS, where cancer cells completely fill the duct. The next non-invasive breast malignant condition is Paget disease of the breast. Paget disease occurs when ductal carcinoma, either in situ or invasive, extends up to the lactiferous ducts and into the nipple and areola. So you have to know that women with this condition typically present with an eczematous skin lesion or persistent dermatitis in the nipple and adjacent areas. The diagnosis of Paget disease of the breast is established by obtaining a biopsy, but women with Paget disease must undergo mammography to detect the presence of underlying breast cancer. Histologically, Paget disease of the breast demonstrates Paget cells, which are intraepithelial adenocarcinoma cells. As far as the treatment goes, the initial management of Paget disease of the breast is a mastectomy. In addition, Paget disease of the breast that is positive to estrogen receptors can be treated using an estrogen receptor antagonist, like tamoxifen. Finally, there's lobular carcinoma in situ, or LCIS, which arises in lobules and acini of the terminal duct lobular unit. LCIS is not associated with the classic presentation of breast cancers, like a palpable breast lesion, radiological features, or microcalcifications. Instead, it's most commonly diagnosed as an incidental finding on biopsy for some other mass lesion, like fibroadenoma. Finally, for your exam, you have to remember that LCIS is associated with an increased risk for breast cancer developing in both breasts, in contrast to DCIS, where the risk is increased in the affected breast. Now, switching gears and moving on to invasive breast cancers, which typically present as a poorly defined, firm, palpable breast mass or a mammographic finding. As breast cancer invades surrounding breast tissue, it can infiltrate pectoral muscles and deep fascia, thereby forming immobile masses. Moreover, infiltration of the central region of the breast can lead to nipple retraction, while the invasion of the suspensory Cooper ligaments leads to the retraction of the overlying skin. Finally, if the cancer cells obstruct the dermal lymphatics, they can cause lymphedema and thicken skin around exaggerated hair follicles, eventually giving the skin an appearance of an orange peel, also referred to as peau d'orange finding. Invasive breast cancers include invasive ductal breast carcinoma, invasive lobular breast carcinoma, medullary breast carcinoma, and inflammatory breast carcinoma. First, let's focus on invasive ductal carcinoma, which is the most commonly diagnosed type of invasive breast cancer. Typically, it arises from the terminal duct lobular unit and presents as a unilateral firm, fibrous, rock-hard, palpable breast mass with sharp margins. In advanced stages, invasive ductal carcinoma can cause skin dimpling or nipple retraction. Histologically, it's characterized by small glandular cells in the stroma, and it can be tubular or mucinous. Tubular carcinoma is characterized by well-differentiated tubular structures that lack myoepithelium, while mucinous carcinoma is associated with malignant cells that are scattered throughout abundant extracellular mucin. For your exam, you should remember that the mucinous subtype is most commonly seen in older women after they've gone through menopause. Finally, invasive ductal carcinoma has a tendency to metastasize via the lymphatic vessels, and it's also the most common type of breast cancer in males. Moving on to invasive lobular breast carcinoma. This is the second most common type of invasive breast cancer. It's often associated with lobular carcinoma in situ. In contrast to invasive ductal carcinoma, invasive lobular carcinoma is often bilateral, with multiple lesions in the same location that are not palpable on breast examination. A high-yield fact is that this tumor is associated with low E-cadherin expression, which is a gene that codes adhesion proteins that prevent cancer cells from spreading into the surrounding breast tissue. Histologically, invasive lobular carcinoma is characterized by cancer cells that are clustered into strands or chains that invade the adjacent stroma. Lines of cells are associated with invasive lobular carcinoma. Also, there's no duct formation. The next one is medullary carcinoma, which is a type of breast cancer that most commonly presents as a well-circumscribed palpable mass that can mimic benign lesions, like a fibroadenoma. Medullary carcinoma is more common in younger women, and it's associated with BRCA1 mutation and triple-negative phenotype. Histologically, it's characterized by large anaplastic cells that grow in sheets and infiltrates of lymphocytes and plasma cells. Finally, there's inflammatory breast carcinoma, which often affects women younger than 40. Women with inflammatory breast carcinoma commonly present with peau d'orange finding, breast tenderness, pruritus, warm erythematous skin or skin discoloration, which can range from pale pink to deep red and purple. On physical exam, they can lack a palpable mass. Therefore, the condition can be mistaken for mastitis or Paget disease of the breast. Inflammatory breast carcinoma is very aggressive and always locally invasive at the time of diagnosis, which gives it a higher stage and a poor prognosis. Unlike the name would suggest, symptoms are caused by the blockage of dermal lymphatics and not inflammation. On histology, there are tumor cells that invade into the dermal lymphatics in the affected areas. Alright, as a quick recap, breast cancer is the most common malignancy in women, and it's typically seen in postmenopausal women over 50 years of age. Most breast cancers are adenocarcinomas that typically arise from the terminal duct lobular unit, and they can present as an incidental finding on a screening mammogram or as a palpable breast mass. In most cases, they're located in the upper outer quadrant of the breast, and they're evaluated by triple assessment method: clinical examination, imaging methods, like an ultrasound or a mammography, and needle biopsy. Next, breast cancers are subdivided into non-invasive breast cancers and invasive breast cancers. Non-invasive breast cancers include DCIS, which is further subdivided into comido and non-comido DCIS, Paget disease of the breast, and LCIS. On the other hand, invasive breast cancers include invasive ductal carcinoma, invasive lobular carcinoma, medullary breast carcinoma, and inflammatory breast carcinoma. Finally, the treatment of breast cancer includes surgical management, like radical mastectomy or breast-conserving surgery, radiation therapy, and chemotherapy. If the breast cancer is estrogen receptor positive, they will respond to treatment with anti-estrogen medications like tamoxifen, which is a selective estrogen receptor modulator, or aromatase inhibitors like anastrozole. If it's HER2 new receptor positive, it'll respond to trastuzumab, a monoclonal antibody against HER2 new receptors. And that's not all. Here's an overview of the most common benign and malignant breast conditions and parts of the breast that they affect. Feel free to pause the video. Now let's get back to our case. First, there was Cassie, who noticed a new breast mass on her monthly self-examination. A mammogram showed microcalcification clusters, so excisional biopsy was performed, which showed high-grade cells with central necrosis and dystrophic calcifications. Since there was no invasion of the basement membrane, we can say that this is a classic presentation of ductal carcinoma in situ, more specifically comidocarcinoma. On the other hand, Linda complained about chronic eczematous dermatitis of the left nipple and areolar area for the past 24 months. Her history revealed that the lesion was treated unsuccessfully with topical steroids, and physical examination showed scaly, crusty, and deformed left nipple with multiple plaques overlying the surrounding areola. Linda must undergo mammography and detect the possible presence of underlying breast cancer. She most likely has Paget disease of the breast. A biopsy is needed to confirm the presence of Paget cells and to rule out inflammatory breast carcinoma.
Breast cancer, or breast carcinoma, is an uncontrolled growth of epithelial cells within the breast. It's the second most common cancer in women, but can also, on rare occasion, affect men as well. Breast cancer is also the second leading cause of cancer deaths in women, after lung cancer. This is largely due to the fact that, oftentimes, breast cancers don't cause any pain or discomfort until they've spread to nearby tissues. The breasts are milk-producing glands that sit on the chest wall, on either side of the breastbone. They lie on top of the ribs and the pectoral muscles, and they're divided into three main parts. The glandular tissue that makes the milk is made up of 15 to 20 lobules. Inside each of these lie a bunch of grape-like structures called the alveoli, which are modified sweat glands surrounded by a basement membrane made largely of collagen. Zooming in on the alveoli, there's a layer of alveolar cells that secrete breast milk into the lumen, which is the space in the center of the gland. Wrapping around the alveolus are special myoepithelial cells that squeeze down and push the milk out of the lumen of the alveolus, down the lactiferous ducts, and out one of the pores of the nipple. Now, surrounding the glandular tissue is the stroma, which contains adipose or fat tissue, and this makes up the majority of the breast. Suspensory ligaments called Cooper's ligaments run through the stroma and help keep it in place. These ligaments attach to the inner surface of the breast on one end and the pectoralis muscle on the other. Just beneath the skin covering the breast, there's a network of tiny lymphatic vessels that drain the lymph, which is a fluid containing cellular waste products and white blood cells. These lymphatic vessels mainly drain into a group of lymph nodes in the axilla, or the armpit. Now, the cells of glandular tissue have receptors for certain hormones, like estrogen and progesterone, which are released by the ovaries, and prolactin, which is released by the pituitary gland. These hormones stimulate the alveolar cells to divide and increase in number, which makes the lobule enlarge. Without these hormones, the glandular cells, particularly the alveolar cells, can't survive and undergo apoptosis, which is programmed cell death. For example, after menopause, estrogen production stops, which leads to death of the alveolar cells, and over time that breast tissue gets replaced by fat. During the menstrual cycle, there's increased secretion of estrogen and progesterone from the ovaries, and right after menstruation, that secretion decreases. As a result, during every menstrual cycle, the alveolar cells undergo division and apoptosis. Men have some breast tissue as well, but they lack milk-secreting alveoli. Each time cells divide, there's a chance that a genetic mutation will occur, and a mutation can lead to tumor formation. So with more menstrual cycles, there's an increased risk of tumor formation. That's why there's an increased risk of breast cancer with things that increase the number of menstrual cycles, like early age of menarche, which is the first menstrual bleeding, and late age of menopause. Similarly, medications containing estrogen also increase the risk of breast cancer. There are also other environmental risk factors such as ionizing radiation, like from chest x-rays and CT scans. On the flip side, some things that are associated with a decreased risk of breast cancer include early pregnancy and a longer time breastfeeding. Breast cancer has also been linked to specific mutations in tumor suppressor genes, such as breast cancer gene, or BRCA1 and BRCA2, and TP53, which normally slow down cell division or make cells die if they divide uncontrollably. Mutations in BRCA1 or BRCA2 are both autosomal dominant mutations, which can be inherited and cause familial breast cancer. In addition to breast cancer, they also cause an increased risk of ovarian cancer. Some breast cancers also have mutations in the ERBB2 gene that increase human epidermal growth factor receptor 2, or HER2, which, when activated, promotes the growth of cells. In males, breast cancer is usually caused by inherited mutations in the BRCA1 and 2 genes. Once a cancer-causing mutation does occur, the affected cell, which is most commonly an epithelial cell that lines the ducts or the lobules, begins to grow and replicate out of control, forming a tumor. This tumor, also called an in situ carcinoma, is initially localized within the basement membrane of the alveoli and can be of two types. The first type is called ductal carcinoma in situ, or DCIS, and that's where tumor cells grow from the wall of the ducts into the lumen. If left untreated, DCIS over time can cross the basement membrane to become invasive ductal carcinoma. Also, cancer cells from DCIS can migrate along the lactiferous duct and through the pore onto the skin over the nipple. This is called Paget disease of the nipple, These cancer cells release a substance called mobility factor, which helps them break into and settle in between the squamous epithelial cells. As the cancer cells move into the epithelium, there's inflammation, which brings extracellular fluid out through breaks in the skin. This fluid then dries and forms crusts over the skin surface. The second type is called lobular carcinoma in situ, or LCIS, and that's where clusters of tumor cells grow within the lobules without invading the ducts, causing the affected alveoli to enlarge. Unlike DCIS, over time, LCIS doesn't cross the basement membrane to form invasive lobular carcinoma. LCIS got its name many years ago, before it was realized that it's not a breast cancer, in the sense that it doesn't invade surrounding tissues. Just like healthy alveolar cells, some breast cancer cells have hormone receptors that allow them to grow in the presence of the hormones. Based on the type of hormone receptors, breast cancers can be divided into 3 major types: estrogen receptor, or ER-positive and HER2-negative carcinoma, which is most common, HER2-positive and ER-positive negative carcinoma, and ER-negative and HER2-negative carcinoma. Breast cancer can cause a few complications. First, the tumor causes local inflammation, which causes damage to the suspensory ligaments and lactiferous ducts, resulting in their fibrosis. Next, the cancer can invade nearby tissues, like the pectoral muscles below and the skin above. Cancer cells can also enter and block the thin lymphatic vessels, which causes lymph to build up in the interstitial space. Normally, this fluid buildup would cause a swelling, but the attachment of suspensory ligaments doesn't allow the skin to stretch. So, the skin becomes thickened and dimpled, like an orange peel, called peau d'orange appearance. Finally, tumor cells can spread via the blood to the spine, brain, and bone, or the lymph to other sites like axillary lymph nodes and the other breast. In males, breast tissue is very thin, which makes it easier for the cancer to spread to underlying tissues. The first symptom of breast cancer is a hard, painless lump or swelling, which is most commonly in the upper and outer part of the breast. Additionally, there may be a swelling under the armpit, if cancer is spread to the axillary lymph nodes. The breast can become immobile and fixed, or stuck onto the chest wall due to infiltration, if cancer cells spread into the pectoral muscles. Another symptom is dimpling of the skin over the breast due to involvement of the skin. Fibrosis of lactiferous ducts and suspensory ligaments causes retraction, or pulling in of the nipples. When Paget disease is present, it can cause itching, redness, crusting, and discharge from the nipple. Diagnosis of breast cancer usually begins by feeling a breast lump. Breast cancer can be treated effectively when it is detected early in the course of the disease. That's why regular screening with mammography, which is an X-ray of the breasts, is done in high-risk individuals. In addition, imaging using ultrasound and MRI may be done to detect the tumor. Finally, a biopsy of the swelling or a fine needle aspiration and cytology, where fluid from the swelling is taken, may be done to confirm the diagnosis. To determine the risk of breast cancer, each one is staged by the TNM system. T indicates the size of the tumor and whether or not it has grown in nearby areas, for example, the chest wall muscles. N describes the degree to which cancer has spread to nearby lymph nodes, particularly the axillary lymph nodes. And finally, M indicates the degree to which the cancer is spread to other sites or metastasized. Each of these categories is ranked from 0 to 4, with 4 being the most severe. Finally, the combinations of these substages determine the stage group, which are assigned 0 to 4. Treatment for breast cancer is based on the type and stage of the cancer, but commonly involves surgery, radiation therapy, chemotherapy, and hormonal therapy. Localized tumors are removed surgically by partial mastectomy, where the affected part is removed, and larger tumors, which have spread to nearby tissue, are removed by total mastectomy, where the entire breast is removed. In addition, nearby structures like lymph nodes may also be removed if the cancer has metastasized to them. Hormone therapy is used when tumor cells have hormone receptors like estrogen and HER2, and may include medications which block the formation or effects of estrogen. Alright, as a quick recap, breast cancer or breast carcinoma is the uncontrolled growth of epithelial cells lining the ducts and lobules of the breast. Breast cancer usually begins as an in situ carcinoma, which can either be ductal carcinoma in situ, or DCIS, which is localized to the ducts, or lobular carcinoma in situ, or LCIS, which is localized within the lobules. Over time, in situ carcinoma can invade the basement membrane to become invasive carcinoma, involving the ducts and lobules. Breast cancer screening by mammography is done for early detection of cancer, which can be treated by a variety of treatment options, including surgery, radiation therapy, chemotherapy, and hormonal therapy.
Postpartum hemorrhage is worrisome when more than 500 milliliters of blood are lost after a vaginal delivery, or more than 1,000 milliliters of blood are lost after a C-section. Postpartum hemorrhage usually occurs in the 24 hours following delivery, in which case it's called early or primary postpartum hemorrhage. But in rare situations, it happens later than 24 hours after delivery, and that's when it's called late or secondary postpartum hemorrhage. Postpartum hemorrhage, like any ongoing bleeding, can be classified according to the degree of hypovolemia and vital sign status. Stage 1 is when 500 to 1,000 milliliters of blood have been lost. Blood pressure is usually normal, but there may be palpitations, tachycardia, and slight dizziness. Stage 2 is when 1,000 to 1,500 milliliters have been lost. Systolic blood pressure drops to 80 to 100 milligrams of mercury, tachycardia is obvious, and there may be weakness and sweating. Stage 3 is when 1,500 to 2,000 milliliters have been lost. Systolic blood pressure drops between 70 and 80 milligrams of mercury, and there may be restlessness, pallor, and low urine output. Finally, stage 4 is when more than 2,000 milliliters have been lost, systolic blood pressure is less than 70 millimeters of mercury, and symptoms may include cardiovascular and respiratory collapse, loss of consciousness, and anuria. Now, before elucidating the cause, some immediate measures should be taken in order to compensate for blood loss. These follow an ABC pattern. A stands for airway, so you'll want to protect the airway, especially when there's loss of consciousness. B stands for breathing, so you'll want to administer oxygen through a non-rebreather mask. C stands for circulation, meaning measuring vital signs and establishing the degree of hypovolemia, inserting 2 large caliber peripheral IV catheters of at least 14 gauge or even larger gauge, and starting fluid resuscitation immediately with 500 milliliters of normal saline or lactated ringer solution given over 30 minutes. Afterwards, the rate of fluid is adjusted depending on their hemodynamic status. In females who have lost more than 1,500 milliliters of blood, blood transfusions are indicated, typically with products containing both red blood cells and platelets. The definitive management of postpartum hemorrhage depends on the underlying cause. The most common cause of postpartum hemorrhage can be remembered as 4 T's: tone, trauma, tissue, and thrombin. Tone refers to uterine atony, which is the predominant cause of bleeding. Trauma refers to damage to the genital tract structures, like vaginal or cervical lacerations or hematomas, perineal tears, or uterine rupture. Tissue refers to the tissues within the placenta and other fetal tissues. And thrombin is a T word to help you remember coagulation disorders. Finally, another cause aside from the 4 T's is uterine inversion, which is when the placenta fails to detach from the uterine wall and pulls the uterus inside out as it exits. So a T phrase to remember this might be turned inside out. So, let's start off with uterine atony. Normally, after delivery, the uterus continues to contract, which squeezes shut the spiral arteries that used to nourish the placenta, therefore reducing uterine bleeding. With uterine atony, though, the uterus doesn't contract properly, so the spiral arteries don't clamp down, which leads to excessive bleeding and postpartum hemorrhage. Risk factors for uterine atony are uterine overdistension, so anything that makes the uterus stretch out too much, like pregnancies with more than 1 fetus, more than 4 previous deliveries, or hydramnios, which is too much amniotic fluid. Uterine atony can also occur when the uterine muscles fatigue during the delivery process because of a prolonged labor, which is defined as labor lasting more than 20 hours in a first delivery or more than 14 hours in females who have previously given birth. Additionally, prior C-sections or uterine surgery, as well as a full bladder, which can develop in females that are unable to pass urine following anesthesia, can all make it harder for the uterus to fully contract. Finally, some obstetric medications like anesthetics, especially halothane, as well as magnesium sulfate, nifedipine, and terbutaline can all increase the risk of uterine atony. To prevent uterine atony, prophylactic uterotonic medication should be given to all females during the third stage of labor, most frequently following delivery of the placenta. Oxytocin is usually the go-to option, either as an IV infusion, 10 to 40 international units of oxytocin in 500 to 1,000 milliliters of 0.9% saline, or 10 international units of oxytocin as an intramuscular injection. Alternatives include prostaglandin E1 analogs like misoprostol, a 15-methyl-prostaglandin F2 alpha derivative like carboprost-tromethamine, ergot alkaloids like ergonovine or methylergonovine, and a longer-acting relative of oxytocin called carbetocin. In females with no risk factors or at low risk for uterine atony, any single one of these agents is recommended. In females at high risk for uterine atony, combinations like oxytocin and misoprostol or oxytocin and methylergonovine are recommended. The diagnosis of uterine atony is clinical. On palpation, the uterus feels boggy, soft, and enlarged, and the vaginal examination confirms that the predominant bleeding is not coming from a vaginal or cervical laceration. Although sometimes there can be some birth canal trauma along with uterine atony. After supportive measures have been undertaken, definitive treatment for uterine atony starts with uterotonic medication and bimanual uterine massage. Usually, oxytocin is given in the same dose used for prevention, so either an IV infusion, 10 to 40 international units of oxytocin in 500 to 1,000 milliliters of 0.9% saline, or 10 international units of oxytocin as an IM injection. If that doesn't control the bleeding, a second uterotonic medication like methylergonovine, carboprost-tromethamine, or misoprostol may be used. Another medication which may be used in conjunction with uterotonics is tranexamic acid, a synthetic analog of lysine. Tranexamic acid has antifibrinolytic activity, so it prevents clot degradation. 1 gram is usually given within 3 hours of delivery, and if bleeding persists after 30 minutes, another 1 gram dose may be given. In the meantime, epidural or spinal anesthesia may be given, and a bimanual uterine massage can be done to control the bleeding. This is done with one hand on the abdomen, which massages the uterine fundus, and the other hand made into a fist, which is inserted into the vagina, specifically all the way up to the anterior vaginal fornix, and pressed against the anterior uterine wall. Direct pressure helps compress the spiral arteries to help control the bleeding, and it helps stimulate uterine contractions as well. If uterotonic medication and uterine massage doesn't stop the bleeding, and the female is hemodynamically stable, then intrauterine balloon tamponade can be done. That's where a tool called the Bakri postpartum balloon, which is a catheter with a balloon at the tip, is inserted into the uterus under sonographic guidance. Then, the balloon is slowly inflated with saline to help tamponade the bleed from within. Another technique is uterine artery embolization, which is an interventional radiology technique. This is when a catheter is inserted through the femoral artery and advanced up to the uterine arteries. Then, a contrast agent is injected, and the site of the bleeding is where the contrast seems to spill out of the vessel. Embolization is done by inserting a gel through a catheter to plug either the left or right uterine artery, depending on where the bleeding seems to be coming from. Finally, if the bleeding still doesn't stop, then surgical ligation of the uterine arteries or a hysterectomy can be done, but those are done as a last resort. Alright, now the second most common cause of postpartum hemorrhage is trauma. So, any kind of injuries to the birth canal, like cervical or vaginal lacerations or hematomas, perineal tears, or uterine rupture. Risk factors include a large fetus, hasty deliveries, and iatrogenic causes like an episiotomy, which is when an incision is made to enlarge the vaginal opening in order to allow the baby to pass through. Cervical and vaginal lacerations can be seen on a speculum examination, and treatment is surgically suturing the laceration under local anesthesia. With hematomas, symptoms include labial, rectal, or pelvic pressure or pain. For small hematomas in hemodynamically stable females, IV fluids are given and the hematoma typically resorbs on its own. For rapidly expanding hematomas, or in hemodynamically unstable females, IV fluids and blood transfusions along with incision and drainage of the hematoma may be required. Perineal tears can be seen on inspection, and they're classified into 4 degrees. First-degree tears are when the tear doesn't go past the fourchette, which is where the 2 labia minora meet posteriorly. Second-degree tears extend past the fourchette, but they don't involve the anal sphincter. Third-degree tears may extend as far as the internal anal sphincter. Finally, fourth-degree tears reach all the way to the rectal mucosa. Depending on the degree, perineal tears may be sutured under local or general anesthesia. Uterine rupture is rare, but it's a severe and traumatic cause of postpartum hemorrhage. One risk factor is having a previous C-section. It typically causes sudden and severe abdominal pain. In some cases, blood may be intraperitoneal or retroperitoneal instead of flowing out through the vagina, in which case an ultrasound is needed to see the accumulation of blood. Treatment relies on emergency surgery to repair or remove the uterus. Okay, now our third T, or tissue, refers to placental fragments retained in the uterine cavity. This usually happens with placenta accreta or related disorders, or when there's an accessory placental lobe. Placenta accreta refers to invasion of the placenta into the uterine wall, and it comes in 3 flavors depending on depth. First, there's placenta accreta per se, which is when the placenta is burrowed deep into the endometrium, but doesn't reach the myometrium. Second, there's placenta increta, which is when the placenta has invaded the myometrium, but doesn't go all the way through. Finally, there's placenta percreta, which is when the placenta invades all the way through the myometrium and may extend into neighboring organs. A risk factor for these conditions is prior uterine surgery, especially when the placenta implants itself near a scar from the previous surgery. With these conditions, bleeding results when the placenta has not been removed entirely from the uterus following delivery. You see, the placenta is a frisbee-shaped organ, and the blood vessels that nourish the placenta stop a bit before the border, so that when the placenta detaches from the uterine wall during delivery, there is minimal blood loss. When the placenta is abnormally burrowed, though, it tears from the uterine wall and leaves a little bit of itself behind. And you guessed it, that little bit still has placental vessels which can cause postpartum hemorrhage. The diagnosis is made by closely inspecting the placenta after delivery. If the placental vessels seem to stop at the very edge, then there's probably some of the placenta that's left behind. On palpation, the uterus feels firm, and an ultrasound will show the retained placental tissue as a hyperechoic mass. Treatment of placenta accreta depends on the depth of invasion. Small focal accreta can usually be removed with curettage, which is where a curette is used to scrape the tissue from the uterine wall. However, more frequently, the placenta is burrowed more deeply into a large portion of the uterine wall, so a hysterectomy is usually required to stop the hemorrhage. In these cases, manual removal of placenta accreta should not be attempted because it can severely worsen the hemorrhage and can sometimes be life-threatening. Finally, the last one of the 4 T's is thrombin, which refers to postpartum hemorrhage due to a coagulation disorder. Sometimes, the cause is a clotting disorder like hemophilia. Other times, there's a coagulopathy secondary to another obstetric condition like preeclampsia, placental abruption, and an amniotic fluid embolism. All of these can progress to disseminated intravascular coagulation, or DIC, which uses up platelets and clotting factors, so that normal hemostasis can't occur. Regardless of the cause, coagulation disorders can usually be identified by lab abnormalities like a high INR, prolonged PT, PTT, low platelets, or low levels of deficient clotting factors. Fibrinogen may be low or normal, but bear in mind that a normal fibrinogen level between 150 and 400 milligrams per deciliter is low for a postpartum female, since fibrinogen levels usually increase during pregnancy. Treatment relies on blood transfusions, red blood cells, platelets, fresh frozen plasma, or cryoprecipitate. Finally, aside from the 4 T's, uterine inversion can also cause postpartum hemorrhage. With uterine inversion, the uterine fundus descends through the cervix and into the vagina, kind of like turning a bag inside out. This is different from uterine prolapse, which is when the ligaments that hold the uterus in place become weaker, and the cervix and uterus glide into the vagina, but cervix first, and nothing gets turned inside out. Okay, Now, uterine inversion can be diagnosed on palpation, which will surprisingly find an empty pelvis, so the uterine fundus is missing from the pelvis. There are 4 degrees of uterine inversion. First degree is when the uterine fundus is just a little bit collapsed on itself and doesn't reach the cervix. Second degree is when the uterine fundus reaches the cervix, and this can be seen as a red mass, the inside of the uterus, protruding into the vagina. Third degree is when the uterine fundus reaches the vulva. And finally, 4th degree inversion is when the uterus is completely inverted and outside the vulva. Treatment starts with administering uterine relaxants like magnesium sulfate, halogenated anesthetics, and nifedipine. Then, the uterus can be manually put back in place. If unsuccessful, surgery may be required to put the uterus back in place. Alright, as a quick recap. The most common causes of postpartum hemorrhage can be remembered as tone, trauma, tissue, and thrombin. Uterine atony is the most common of them, and on palpation, the uterus feels enlarged, soft, and boggy. Prophylactic measures involve administering uterotonic medications like oxytocin, misoprostol, methylergonovine, or carbetocin after placental delivery, and treatment relies on administering the same medications as well as bimanual uterine massage. Other options include intrauterine balloon tamponade, uterine artery embolization or ligation, and hysterectomy as a last resort. Trauma refers to cervical or vaginal lacerations or hematomas and uterine rupture. Lacerations can be sutured and small hematomas can be managed conservatively, whereas rapidly expanding hematomas can be incised and drained. For uterine rupture, emergency surgery is required to either repair or remove the uterus, depending on where and how much it has ruptured. With retained placental tissue, most often due to the placenta accreta spectrum, the uterus feels firm on palpation and an ultrasound can show the retained tissue. Small focal placenta accreta can be removed through curettage, but most other cases require a hysterectomy. Then there's primary coagulation disorders like clotting factor deficiencies and coagulopathies secondary to preeclampsia, placental abruption, or amniotic fluid embolism, which can cause postpartum hemorrhage or disseminated intravascular coagulation. Lab work shows a high INR, prolonged PT, PTT, low platelets, low clotting factors, and low or normal fibrinogen levels depending on cause. Treatment relies on transfusing red blood cells, platelets, fresh frozen plasma, or cryoprecipitate. Finally, aside from the 4 T's, uterine inversion can also cause postpartum hemorrhage and is diagnosed when the inside of the uterus is protruding into the vagina. Treatment is to administer uterine relaxants and manually put the uterus back in place, or surgery if that was unsuccessful.
Postpartum hemorrhage is a significant loss of blood after giving birth, and it's the #1 reason for maternal morbidity and maternal death around the world. Specifically, it's defined as losing more than 500 milliliters of blood after a vaginal delivery, or more than 1,000 milliliters after a cesarean section delivery. Of course, deliveries can be messy, and it's impossible to measure the precise amount of blood that's lost, and there's the possibility of internal bleeding. So additional criteria to consider for postpartum hemorrhage include a decrease of 10% or more in hematocrit from baseline, as well as changes in the mother's heart rate, blood pressure, and oxygen saturations, all of which suggest a significant blood loss. Significant bleeding in the first 24 hours after delivery is called primary postpartum hemorrhage, and after that it's called secondary or late postpartum hemorrhage. The most common causes of postpartum hemorrhage can be lumped into 4 groups, which can easily be remembered as the 4 T's: tone, trauma, tissue, and thrombin. Tone refers to the lack of uterine tone, also known as uterine atony, basically a soft, spongy, boggy uterus. And this is the main cause of postpartum hemorrhage, generally resulting in a slow and steady loss of blood. Now, the uterus is a muscular organ wrapped by 3 layers of smooth muscle, called the myometrium, which contracts during labor to dilate and efface the cervix and ultimately push out the fetus and placenta. After delivery, the myometrium continues to contract, and this squeezes down on the placental arteries at the point where they're attached to the uterine wall, which clamps them shut, and therefore reduces uterine bleeding. And those contractions continue for a few weeks after delivery. With uterine atony, though, the uterus fails to contract after birth, and those placental arteries don't clamp down, which leads to excessive bleeding and postpartum hemorrhage. Uterine atony can be caused by several things: repeated distension of the uterus as a result of multiple pregnancies, overstretching from twins or triplets, or any condition that causes too much uterine stretching can interfere with efficient uterine contractions and lead to diminished tone and eventual uterine atony. Uterine atony can also happen when the uterine muscles fatigue during the delivery process because of a prolonged labor. It can also happen when a woman is unable to empty her bladder, since a full bladder can push against the uterus and interfere with uterine contractions. Finally, some commonly used obstetric medications like anesthetics, especially halothane, as well as magnesium sulfate, nifedipine, and terbutaline can all interfere with uterine contractions and increase the risk of uterine atony. Uterine atony can be treated by fundal massage, or massaging the fundus, the upper section of the uterus, which is typically near the umbilicus right after birth. Fundal massage causes the smooth muscle in the uterine wall to contract and harden. If a full bladder seems to be interfering with contractions, then a woman can urinate or have a catheter placed if she can't void by herself. Medication to help firm up the uterus can also be given, and if necessary, the bleeding might be stopped surgically. Alright, the next T, trauma, refers to damage to any of the genital structures: the uterus, cervix, vagina, and perineum. This can include the incision from a cesarean delivery, incidental trauma from a baby coming through the vaginal canal, or trauma from instruments used in delivery. For example, the use of forceps, vacuum extraction, or an episiotomy, a small cut used to enlarge the vaginal opening, which can also cause unintended bleeding. Sometimes that bleeding's in a concealed location, and a hematoma can form, which is a mass or collection of blood, and go unnoticed for hours after delivery. A key to recognizing hematoma is severe pain and persistent bright red vaginal bleeding, in spite of a firmly contracted uterus. In general, any trauma-related bleeding is an emergency, and the site of bleeding has to be repaired right away, generally by applying pressure and stitching lacerations. The next T, tissue, refers to placental fragments retained in the uterine cavity. The entire placenta normally separates from the uterine wall in the third stage of labor, but occasionally a part of the placenta can stay behind in the uterus. In placenta accreta, the placenta invades the myometrium, so it doesn't easily separate from the uterus. Placenta accreta, or just too much traction on the umbilical cord, can both cause the placenta to be retained. This in turn prevents effective uterine contractions and leads to uterine atony. The goal with this one is to prevent it from happening in the first place, by making sure that the placenta comes out completely intact, and removing any tissue that does get retained as soon as possible. Thrombin, the final T, refers to the mother having some condition that prevents blood clots from forming normally. For example, a genetic disorder like von Willebrand disease, or an obstetric condition like eclampsia and placental abruption, which might result in a clotting disorder. And these can lead to disseminated intravascular coagulation, or DIC. These are conditions that prevent a clot from forming normally when there's a bleed, and this can turn even a tiny bleed into a serious problem, since it doesn't stop easily. The treatment for each of these is specific to the underlying cause. Alright, so postpartum hemorrhage is an obstetric emergency, and maintaining adequate circulating volume is a key priority. Regardless of the cause, intravenous fluids and blood products may be used to ensure that the vital organs are well perfused. Alright, as a quick recap, postpartum hemorrhage is the most common cause of maternal morbidity and mortality around the world. And the causes are the 4 T's: tone, trauma, tissue, and thrombin. The most common cause, uterine atony, can usually be managed with fundal massage and medications to help the uterus contract.
Pelvic inflammatory disease, or PID, is an infection of the upper female reproductive system, including the uterus, fallopian tubes, and ovaries. It can cause a number of serious complications, including infertility. The female reproductive system includes all of the internal and external organs that help with reproduction. The internal sex organs are the ovaries, which are the female gonads, the fallopian tubes, two muscular tubes that connect the ovaries to the uterus, and the uterus, which is the strong muscular sac that a fetus can develop in. The neck of the uterus is called the cervix, and it protrudes into the vagina. At the opening of the vagina are the external sex organs, and these are usually just called the genitals, and they're in the vulva region. They include the labia, the clitoris, and the mons pubis. The vagina, uterus, and fallopian tubes all have a mucosa, which is a layer of epithelial cells that lines the inside of these organs. PID usually develops from a bacterial infection in the vagina or the cervix, which causes inflammation of this mucosal layer. About 60% of the time, this changes the composition of the bacterial flora in the vagina, also called bacterial vaginosis. Because the reproductive tract is essentially one long tunnel that starts at the ovaries and ends at the external sex organs, the infection can travel up that tract pretty easily. And some mechanisms can make it even easier. For example, the cervical mucus, which normally acts as a barrier preventing bacteria from entering the uterus, can become less effective. The mucus can become thinner as a result of normal variations throughout the menstrual cycle, or, alternatively, it can become less effective in the context of bacterial vaginosis, which is when the normal balance of the vaginal flora is altered, and anaerobic bacteria proliferate and degrade the cervical mucus. Other factors contributing to an infection may be retrograde menstruation, which is when menstrual blood flows back through the fallopian tubes and into the pelvic cavity instead of out of the body, and also sexual intercourse. Now, PID is most problematic when the infection reaches the fallopian tubes, in which case it's called salpingitis. If it also affects the ovaries, it's called salpingo-oophoritis. The infection triggers a response from the body, which sends in neutrophils, plasma cells, and lymphocytes into the fallopian tubes. That sounds like a good thing, right? But this actually damages the tubal epithelium, and the tubes become filled with pus. When scar tissue forms to repair the damage, areas with damaged epithelium tend to stick to one another, creating closed-off pockets and little dead-end pouches in the fallopian tubes. This scarring in the fallopian tubes can lead to a number of complications related to PID. If pus builds up in the tube and ovary, it can turn into tubo-ovarian abscess, which can be life-threatening if it ruptures. If a watery fluid builds up in a pocket created by scar tissue in the tubes, this is called hydrosalpinx, and it can cause the affected area to become swollen. In general, because of the structural damage it creates in the fallopian tubes, individuals who have had PID tend to have more difficulty getting pregnant and have a higher risk of ectopic pregnancy and chronic pelvic pain. One last complication is Fitzhugh-Curtis syndrome, which occurs when the inflammation from PID spreads to the peritoneum and, from there, to Glissen's capsule, which surrounds the liver. This results in violin string adhesions, or thin strings of scar tissue that attach the liver to the peritoneum. There are many different bacteria that are associated with PID, but the most common are Neisseria gonorrhoeae and Chlamydia trachomatis, which are responsible for the sexually transmitted infections gonorrhea and chlamydia. Occasionally, PID can be caused by other forms of bacteria introduced into the reproductive tract by surgery, abortion, or even normal vaginal childbirth. Most of the time, the infection is caused only by one type of bacteria, but in 30 to 40% of cases, it becomes polymicrobial. Essentially, the original infection makes it easier for other bacteria to settle into the reproductive tract. Because of the relationship with chlamydia and gonorrhea infections, sexually active females, particularly those that have multiple sexual partners and don't use condoms, are at most risk of developing PID. Some women will have few or no symptoms of PID. When there are noticeable symptoms, they include pelvic pain, tenderness around the ovaries and fallopian tubes, fever, and abnormal vaginal discharge. Diagnosis of PID is usually based on clinical findings, particularly pelvic pain and cervical motion tenderness, which is when mobilizing the cervix during a vaginal exam causes pain or discomfort. Tenderness in the right upper quadrant of the abdomen is also common if Fitzhugh-Curtis syndrome has developed. There's no specific test for PID, but there are some that can support the diagnosis, like testing vaginal discharge for signs of bacterial vaginosis, doing a nucleic acid amplification test to look for chlamydia and gonorrhea DNA in a sample taken from the inside of the vagina or cervix, or doing a laparoscopy of the fallopian tubes. An ultrasound can show if there's fluid in the fallopian tubes and whether a tubo-ovarian abscess or hydrosalpinx is present. Treatment involves giving a mix of antibiotics, usually an injection of ceftriaxone or cefotetan, followed by 14 days of oral doxycycline and metronidazole to treat the bacterial infection responsible for PID. Acetaminophen can be given to manage the pain until the antibiotics have treated the infection. Occasionally, surgery is needed to remove adhesions that are causing pain or to treat complications of PID, such as tubo-ovarian abscesses and hydrosalpinx. Alright, as a quick recap, pelvic inflammatory disease is an infection of the upper female reproductive system. It causes inflammation of the mucous membrane of the inner reproductive tract, which damages the epithelium and results in scarring and adhesions, particularly in the fallopian tubes. It's usually caused by Neisseria gonorrhoeae and Chlamydia trachomatis, which are the bacteria responsible for chlamydia and gonorrhea. Complications include infertility, ectopic pregnancies, and tubo-ovarian abscesses.
In ectopic pregnancy, ectopic means out of place. So an ectopic pregnancy means that a pregnancy happened somewhere other than in the uterine cavity. In order for an ectopic pregnancy to take place, a couple of things need to happen differently from the normal process of a pregnancy. First, following ovulation, the egg must be fertilized and come to rest somewhere other than the endometrium of the uterine cavity. Next, when it arrives at this destination, it must implant on a surface with a rich enough blood supply to support a developing embryo. Ectopic pregnancies have been known to happen on various surfaces, including the ovaries, intestines, and most commonly in the ampulla of the fallopian tube. After implantation, the embryo starts developing and growing just like it would in a normal pregnancy. Over time, a few different things can happen. Sometimes the tissue can no longer provide a sufficient blood supply for the embryo, leading to its death. On the other hand, if the tissue can supply the embryo with sufficient blood, then hormones from the corpus luteum and placenta can lead to a missed menstrual period and other body changes like nausea and fullness of breasts, which are typically seen in early pregnancy. If the ectopic pregnancy happens in the ampulla of the fallopian tube, it eventually runs out of space. Slowly, the ectopic pregnancy stretches the nerve fibers within the wall of the fallopian tube, causing lower abdominal pain. Eventually, the expansion causes damage to the wall of the ampulla, potentially rupturing the fallopian tube. A ruptured ectopic pregnancy can lead to massive hemorrhaging into the abdominal cavity, and the blood can irritate the peritoneum, which can cause referred pain to the shoulder. Occasionally, there might be light vaginal bleeding as well. The combination of internal bleeding, severe pain, and damage to the fallopian tube make an ectopic pregnancy a medical emergency. The cause of an ectopic pregnancy in any individual is often unknown, but there are well-known risk factors. These include smoking, a history of pelvic inflammatory disease, conception by in vitro fertilization, gynecologic surgery, current use of intrauterine devices, tubal ligation, or a previous ectopic pregnancy. Symptoms of an ectopic pregnancy include amenorrhea, or a missed menstrual period, pelvic pain, and vaginal bleeding. Typically, for an ectopic pregnancy in the fallopian tube, pressure increases as the tube stretches around 6 to 8 weeks into the pregnancy. But if the ectopic pregnancy happens in a place with a lot of space for the embryo to grow, pain and bleeding might not happen until several weeks later. A physical exam might show a palpable mass near the uterus and abdominal tenderness. But these symptoms mimic a normal pregnancy, and that can contribute to a delay in diagnosis. Diagnosis of an ectopic pregnancy can vary based on a woman's health. It's important to establish that she's hemodynamically stable, meaning her vital signs are within normal limits, with no evidence of hypotension or tachycardia. If the woman is hemodynamically unstable, then immediate surgery might be needed to diagnose and treat the ectopic pregnancy. If the woman is hemodynamically stable, then serial HCG testing can be done to ensure that levels are doubling approximately every 2 days, which is typical in an early pregnancy. In addition, transvaginal ultrasound can be used to image the inside of the uterus to see whether or not there's intrauterine pregnancy, which is typically visible by week 5 or 6 of the pregnancy. The transvaginal ultrasound can also help identify an ectopic pregnancy based on signs like excess fluid in the peritoneal cavity. In a hemodynamically stable woman whose ectopic pregnancy is diagnosed early and the HCG is already declining, treatment might include close monitoring of the woman's health with serial HCG measurements, with no additional medications or procedures. If the ectopic pregnancy is identified later, then methotrexate can be used to terminate the pregnancy. In a hemodynamically unstable patient, a salpingostomy might be done. That's where the fallopian tube is opened up to remove the pregnancy, and then closed at the end of surgery. Alternatively, a salpingectomy can be done, which is where the fallopian tube is completely removed. Alright, as a quick recap. An ectopic pregnancy happens when a fertilized egg implants somewhere other than the endometrium of the uterine cavity. Risk factors include smoking, pelvic inflammatory disease, in vitro fertilization, pelvic surgery, intrauterine devices, tubal ligation, and previous episodes of ectopic pregnancy. Treatment depends on whether the woman is hemodynamically stable or not, and might include close monitoring, methotrexate, or surgery.
Gestational trophoblastic disease includes both benign and malignant proliferations of placental cells. At the benign end of the spectrum, there's moles. And no, we're not talking about the cute little brown ones above the upper lip. In this case, moles refer to a molar pregnancy, and they're also called hydatidiform moles. At the malignant end, there's invasive moles, which derive from the benign moles, and choriocarcinoma, which is a placental cancer that most frequently occurs in the absence of a molar pregnancy. Risk factors for molar pregnancies include maternal age extremes, like younger than 20 or older than 35, and a previous molar pregnancy. Moles result from errors in normal fertilization. Normally, at fertilization, a single egg with 23 chromosomes fuses with a single sperm with 23 chromosomes, resulting in a new organism with 46 chromosomes. This can go wrong in 2 ways, so we have 2 kinds of moles: complete or classic, and incomplete or partial moles. Both lead to an abnormal proliferation of placental cells and an abnormal placenta. The difference is that a complete mole appears when a chromosomally empty egg fuses with a normal sperm, and the sperm's genetic material duplicates to form a 46 chromosome organism. However, this organism doesn't have both maternal and paternal chromosomes, so the mole develops into a mass rather than developing into a fetus. An incomplete mole, on the other hand, appears when a normal egg is fertilized by 2 sperms, which forms an organism with 69 chromosomes that usually develops into non-viable fetal parts. With a complete mole, the placenta secretes a huge amount of HCG, so affected females present with signs of pregnancy, like missed periods, and a positive urine pregnancy test. Vaginal bleeding is another sign, which may range from light spotting to heavy bleeding, and parts of the mole may even be eliminated, and they look like grapes or cherry-like clusters. Additionally, this huge amount of HCG leads to hyperemesis gravidarum, which is extreme nausea and vomiting, and can lead to severe dehydration. Interestingly, HCG has a subunit that's similar to TSH, FSH, and LH. This causes symptoms of hyperthyroidism, like insomnia, anxiety, tachycardia, and palpitations, as well as the formation of theca lutein cysts on the ovaries, which can cause adnexal mass symptoms like pain or pressure on the affected side. Finally, since the mole grows much faster than a normal pregnancy would, a physical examination shows a uterus that's too big for gestational age. An incomplete mole also secretes more HCG than normal, but not quite as much as a complete mole. So while missed periods and vaginal bleeding may be present, the uterus is not larger than expected for gestational age, and there aren't symptoms of HCG hyperstimulation like hyperemesis gravidarum, hyperthyroidism, or ovarian cysts. Most incomplete moles result in spontaneous abortions during the late first or early second trimester, and the diagnosis is made based on the examination of uterine evacuation contents. Okay, now with both complete and incomplete moles, an HCG level higher than 100,000 milli-international units per milliliter is diagnostic of a molar pregnancy. Sometimes, however, the HCG levels may not reach that threshold, so it can also be diagnosed when a transvaginal ultrasound shows a snowstorm or Swiss cheese pattern. This is a diffuse echogenic pattern resulting from the presence of abnormal placental villi and blood clots. With complete moles, theca lutein cysts may be found on one or both ovaries, and with incomplete moles, fetal parts may be visible, and there's often oligohydramnios. Both complete and incomplete moles are premalignant conditions that can develop into invasive moles. Invasive moles tend to metastasize to the lungs, so a chest X-ray should be part of the workup. If hyperthyroid symptoms are present, serum TSH will be low and serum free T4 will be high. So the mainstay of treatment for both complete and incomplete moles is uterine evacuation, and this is typically done through suction curettage under anesthesia. Prophylactic uterotonic medication, like oxytocin, is given along with anesthesia to prevent hemorrhage after evacuation. Suction curettage per se involves three main steps. First, the cervix is mechanically dilated, and then the uterine contents are suctioned out, and finally curettage is done to scrape any remaining tissue from the uterine walls. The uterine evacuation contents should always be examined histologically for a definitive diagnosis. After uterine evacuation, it's important to get follow-up serial HCG levels to ensure that the premalignant cells are gone. The typical approach is to measure serum HCG weekly until it's undetectable for 3 consecutive weeks, and then once a month for 6 months. This should be done while the female is on reliable contraception, like the barrier method or oral contraception. If HCG levels rise or plateau, there may be a persistent invasive mole, or there may be a choriocarcinoma. Both of these malignant tumors arise from the abnormal proliferation of trophoblast cells. The difference is that with invasive moles, the chorionic villi become edematous, whereas with choriocarcinoma, the chorionic villi are not edematous. Also, an invasive mole always follows a molar pregnancy, whereas choriocarcinoma can also develop after a non-molar pregnancy, meaning a normal or ectopic pregnancy, or an abortion done for other reasons. A persistent invasive mole is more common after a complete mole, especially when the mole caused the uterus to enlarge, when the serum HCG level was over 100,000 milli-international units per milliliter, or where there are theca lutein cysts on the ovaries. The diagnosis is made when HCG levels plateau, meaning they remain within 10% of the previous result over a 3-week period, or when HCG levels increase more than 10% across 3 values recorded over 2 weeks, or when there is still detectable serum HCG up to 6 months after evacuation of a molar pregnancy. Choriocarcinoma accounts for a minority of the cases of gestational trophoblastic neoplasia that follow a molar pregnancy, but the diagnosis is the same. It's identified when HCG levels plateau or rise. An ultrasound should be done to rule out pregnancy, even if the female is on reliable contraception. On ultrasound, an invasive mole looks like one or more poorly defined masses in the uterus with anechoic areas, which invade into the myometrium. And on Doppler ultrasound, an invasive mole has anechoic areas with high vascular flow. On the other hand, on ultrasound, choriocarcinoma looks like a single mass distending the uterus. And it looks heterogeneous because it has areas of necrosis and hemorrhage. And on Doppler ultrasound, a choriocarcinoma also has high vascular flow. One unique situation is when a choriocarcinoma develops in the first year after a non-molar pregnancy. In this case, it may be trickier to diagnose because the serum HCG is not routinely being measured. So, these females often develop symptoms like abnormal uterine bleeding or unexplained amenorrhea weeks to months after a pregnancy. Secondly, there may be signs of excess HCG production, like hyperthyroidism or ovarian thecal lutein cysts. And third, there may be lower abdominal pain or pressure because of uterine and ovarian enlargement. And finally, since choriocarcinoma is aggressive, there may be metastatic disease to the lungs, which causes coughing, dyspnea, or hemoptysis, or metastatic disease to the brain, which causes headache, dizziness, nausea, slurred speech, visual disturbances, neuropathy, and hemiparesis. Rarely, a metastatic nodule will develop in the vagina, and these are usually highly vascular lesions that should not be biopsied, because it can cause significant bleeding. When choriocarcinoma is suspected following a non-molar pregnancy, serum HCG values should be determined, and they're usually going to be really high. Additionally, an ultrasound should be done to rule out pregnancy and identify the tumor. The workup for both a persistent mole and choriocarcinoma includes a chest X-ray and a head, abdomen, and pelvic CT to look for metastases and to stage the tumor. Stage 1 tumors are confined to the uterus and there are no metastases. Stage 2 tumors extend to the fallopian tubes, the ovaries, or the vagina. Stage 3 tumors have lung metastases regardless of genital structure involvement. And finally, Stage 4 tumors have metastases in any organs other than the lungs or the genital structures. After staging, a risk score is calculated in order to select a chemotherapy regimen. The risk score is based on variables like age, previous pregnancy, time since last pregnancy, and pretreatment serum HCG, so a baseline value should be determined before treatment is initiated. Tumor-related variables include the size of the largest tumor, site and number of metastases, as well as whether or not prior chemotherapy regimens have failed. Each of these variables is scored from 0 to 4, and a total score is calculated. A score between 0 and 6 suggests a low risk of resistance to single-agent chemotherapy, whereas a score above 6 predicts a high risk of resistance and requires combination chemotherapy. For females with low-risk gestational trophoblastic neoplasia, a single chemotherapy agent is usually used. Options include methotrexate and actinomycin D, and usually methotrexate is preferred because it's effective, cheap, and well tolerated. In addition, methotrexate doesn't cause hair loss like actinomycin D can. However, methotrexate can cause medullary toxicity, so it's often given with folinic acid on alternating days. For example, if an 8-day regimen is used, methotrexate is given on days 1, 3, 5, and 7, and folinic acid on days 2, 4, 6, and 8. For females with high-risk gestational trophoblastic neoplasia, combination chemotherapy is recommended, and the preferred regimen is EMA-CO. EMA stands for etoposide, methotrexate, and actinomycin D, and CO for cyclophosphamide and vincristine, respectively. The O for vincristine is given because it refers to the brand name of that medication, Oncovin. The dash between the two means that they're given alternatively, so 1 week the female will receive 2 days of EMA chemotherapy, and the next week she'll get 1 day of CO, and so on and so forth. Additionally, for high-risk gestational trophoblastic neoplasia, surgery may be needed to resect sites of chemotherapy-resistant disease, or to control complications like bleeding or infection. During treatment, Serum HCG should be checked weekly, and remission is defined as 3 consecutive undetectable levels. After achieving remission, 3 more courses of the last effective regimen should be given as consolidation therapy to reduce the risk of relapse. After consolidation therapy, the individual should use reliable contraception, and serum HCG should be checked monthly until monitoring shows 1 year of normal HCG levels. To end on a cheery note, almost all females with low-risk disease and most females with stage 2, 3, and even 4 high-risk disease achieve a complete cure. Alright, as a quick recap, benign gestational trophoblastic disease includes complete and partial moles. In both cases, the HCG can be above 100,000 milli-international units per milliliter, which is diagnostic of a molar pregnancy. In cases where the HCG level is a bit lower, a transvaginal ultrasound can be done, which shows a snowstorm or Swiss cheese pattern. With complete moles, fecal lutein cysts may be found on one or both ovaries. With incomplete moles, fetal parts may be visible on an ultrasound. Treatment is uterine evacuation through dilation, suction, and curettage. Follow-up includes getting the female on reliable contraception and measuring serum HCG weekly until it's undetectable for 3 consecutive weeks, and then monthly for 6 more months. Gestational trophoblastic neoplasia includes persistent moles and choriocarcinoma, and may be suspected if HCG levels rise or plateau following a molar pregnancy. Choriocarcinoma can also be suspected following a non-molar pregnancy. With both invasive moles and choriocarcinoma, no matter the context, serum HCG levels are usually very high, and an ultrasound should be done to rule out a normal or ectopic pregnancy. Further workup includes a chest X-ray and a head, abdomen, and pelvic CT to stage the tumor and calculate a risk score. A score between 0 and 6 means low risk, so treatment relies on a single chemotherapeutic agent like methotrexate. A score higher than 6 means high risk, and combination chemotherapy regimen like EMA-CO. Remission is defined as 3 consecutive undetectable HCG levels during weekly monitoring. And after remission, 3 more courses of chemotherapy are given as consolidation therapy to reduce the risk of relapse. After consolidation therapy, serum HCG should be measured monthly while the female is on reliable contraception until monitoring shows 1 year of normal HCG levels.
A miscarriage or spontaneous abortion is defined as a pregnancy loss that happens without outside intervention before the 20th week of pregnancy. Pregnancy is so complex that there are many different ways for the process to get off course and for a miscarriage to happen. For example, if there's a chromosomal abnormality in the sperm or egg, then the resulting zygote will have a problem. One of these problems is called aneuploidy, which is when there are missing chromosomes, or additional chromosomes. For example, if there's one member of a chromosome pair missing, that results in 45 chromosomes total, instead of the normal 46, and it's called monosomy. And if there's one extra chromosome joining a pair, that results in 47 chromosomes total, and it's called a trisomy. Some types of aneuploidy are viable, like Turner syndrome or Down syndrome, whereas many are not, and can lead to a miscarriage. Another abnormality is polyploidy, and that's when a zygote receives more than one set of 23 chromosomes from either the sperm or egg, resulting in 3 sets, totaling 69 chromosomes, or even 4 sets, totaling 92 chromosomes. Polyploidy is generally not viable, and leads to a miscarriage. One more abnormality is a translocation. It can either be balanced, where 2 non-homologous chromosomes essentially trade equal amounts of DNA, or unbalanced, where the chromosomes exchange unequal amounts of DNA, resulting in either too many or too few copies of certain genes on the involved chromosomes. Now, even if a parent carries a balanced translocation, the sperm or egg might end up with an unbalanced translocation, and the zygote won't have a normal number of genes. Some translocations are viable, whereas again many are not, and can lead to a miscarriage. Now, let's say that there are a normal number of chromosomes present, and that the zygote becomes a blastocyst and tries to implant. There are still many ways in which a miscarriage can happen. First, if the blastocyst fails to implant into the endometrial lining of the uterus, then it won't find a blood supply, and it stops growing and gets reabsorbed. Secondly, if the blastocyst implants in tissue other than the endometrial lining of the uterus, like the fallopian tube, it's called an ectopic pregnancy. In the majority of cases, ectopic pregnancies won't have the space or blood supply necessary to support a developing pregnancy. As a result, the blastocyst stops growing and is reabsorbed. If the blastocyst does implant in the endometrium and continues its development, it relies on the corpus luteum to maintain the pregnancy. And one hypothesis is that a miscarriage can happen if the corpus luteum fails to secrete enough progesterone. Finally, as the pregnancy continues and the placenta develops, the fetus starts to rely on the placenta to maintain the pregnancy. If the placenta is unable to secrete sufficient levels of hormones or provide the fetus with a sufficient blood supply at any point, the fetus can stop growing and a miscarriage can happen. During the embryonic period, which is between the 3rd and 8th weeks of pregnancy, the fetus is especially vulnerable to damage from teratogens, which refers to anything that disturbs normal development, potentially resulting in a birth defect or death of the fetus. The list of environmental teratogens is long. It includes things like medications, like isotretinoin, as well as alcohol, recreational drugs like cocaine, tobacco smoke, and heavy metals like mercury. Vital organs like the heart and brain are developing quickly during the embryonic period, and teratogens can cause them to have severe abnormalities. Between weeks 10 through 14 of pregnancy, chorionic villus sampling can be performed to assess the growing fetus. That's when either a needle or a catheter is used to grab a small sample of the placenta, so that a genetic analysis can be done on fetal cells from the placenta. Around week 15, amniocentesis can be performed instead of chorionic villus sampling. That's when a needle is placed into the amniotic fluid to pull out some fetal cells. These procedures are usually well tolerated, but they both have a small risk of causing trauma and introducing an infection, both of which could lead to a miscarriage. Other traumatic causes of miscarriage include motor vehicle accidents and accidental falls. As the fetus grows throughout the pregnancy, uterine abnormalities can also become an issue. For example, if there's a septate uterus, which is where there's a septum or a thin flap of tissue within the uterine cavity, or if there's a submucosal leiomyoma, also called a submucosal fibroid, then it limits the amount of space available for the growing fetus, and this can lead to a miscarriage. In addition, bacteria like Listeria monocytogenes, protozoa like Toxoplasma gondii, or viruses like cytomegalovirus and herpes simplex virus might infiltrate the uterus or pass through the placenta to get to the growing fetus. A severe fetal infection can lead to a miscarriage. Finally, various maternal diseases can also affect the fetus. This includes obesity, endocrine disorders like diabetes mellitus, thyroid dysfunction, or PCOS, which stands for polycystic ovary syndrome, immune system disorders like antiphospholipid syndrome or systemic lupus erythematosus, which can also increase the likelihood of blood clotting, and high blood pressure, which damages the blood vessels, including those of the placenta. Increasing age of either parent is also a risk factor. The diagnosis of a miscarriage is based on the stage of the pregnancy. A threatened miscarriage or threatened abortion is what it's called if there's bleeding from a closed cervix, and an ultrasound confirms the fetus is viable. This happens quite commonly in pregnancy, and most of the time it does not result in a miscarriage. Next, there's an inevitable miscarriage, which is when bleeding comes from an open cervix. This is typically accompanied by abdominal cramping pain, and uterine contents, like the placenta or fetus, are often visible during pelvic examination. After that, there's an incomplete miscarriage, which is when the uterine contents have begun to pass through the open cervix. If the uterus becomes infected during this process, it's called a septic abortion. That infection can spread from the genital tract to nearby structures in the bloodstream, resulting in a potentially life-threatening situation for the woman. Finally, a complete miscarriage is when the uterine cavity is empty and the cervix is closed once again. Now, there's also something called a missed miscarriage. And that's when the fetus is no longer viable, but the cervix has not opened to allow the passage of the placenta and fetus. A missed miscarriage can happen with or without symptoms like bleeding or pelvic pain. Symptoms of a miscarriage depend on how far along the pregnancy is. A miscarriage in the first few weeks of pregnancy might go completely unnoticed, or might result in a relatively small amount of vaginal bleeding with or without the passage of embryonic material that appears like blood clots. As the pregnancy gets further along, miscarriages are more likely to produce lower abdominal pain and more vaginal bleeding, and passage of placental and fetal tissue, which are called products of conception. Diagnosis of a miscarriage can be done using a transvaginal ultrasound, pelvic examination, and laboratory tests like measuring the serum HCG levels to determine whether it's appropriate for the gestational age. Treatment of a missed, incomplete, or inevitable miscarriage might include expectant management, which involves close monitoring while the miscarriage goes to completion without medical intervention. Sometimes medications like misoprostol can be used to induce labor, or surgical options like dilation and curettage or uterine aspiration can be done. A complete miscarriage typically requires no medical intervention. Treatment of a septic miscarriage might involve antibiotics and surgical intervention. In many countries, women whose blood type is Rhd negative and who do not already have anti-D antibodies in their blood are given Rhd immune globulin when they have vaginal bleeding during pregnancy, or soon after the diagnosis of a miscarriage. This prevents the development of antibodies that can cause harm to future pregnancies. Lastly, social and mental health support are crucial for anyone affected by a miscarriage. Alright, as a quick recap. A miscarriage, or spontaneous abortion, is defined by many organizations as a pregnancy loss that happens without outside intervention before the 20th week of pregnancy. There are many known risk factors, including chromosomal abnormalities, teratogen exposure, increasing parental age, physical uterine abnormalities, autoimmune disorders like antiphospholipid syndrome, and severe trauma. A very early miscarriage might produce no noticeable symptoms, while vaginal bleeding and lower abdominal pain become more common as the pregnancy progresses. Treatment might include expectant management, surgery, or medications to induce labor. With germ cell ovarian cancer, germ cell refers to the precursor cells that develop into eggs. Ovarian refers to ovary, of which there are two that sit on either side of the uterus, which is where the germ cells live. So a germ cell ovarian cancer refers to situations where these precursor germ cells become cancerous and form tumors. During fetal development, the entire body derives from three layers, called germ layers: the ectoderm, mesoderm, and endoderm. These germ layers are made of germ cells, and the germ cells migrate out and differentiate into all of the different types of tissues. For example, some ectodermal germ cells become cells of the brain and spinal cord. Some mesodermal cells form bone and muscle, and some endodermal cells become cells in the gastrointestinal tract. Some very special germ cells, though, stay as germ cells, meaning that unlike the cells that differentiate, these germ cells retain their ability to turn into other cell types. They're like ancient little shapeshifters. Normally, during development, these germ cells head to the ovary in women or testicle in men, where they remain for decades, eventually developing into eggs or sperm, respectively. Now, if those germ cells in the ovaries start to divide uncontrollably, it can either form a benign tumor, which means that it doesn't invade nearby tissue or spread to other parts of the body, or it can be a malignant tumor, which means that it can both invade and spread to other tissues. Compared with benign tumor cells, Malignant tumor cells have key features like not having a clearly defined border or slightly less organized nuclei. Now, there are 4 types of germ cell tumors, and each type is named after the type of cell that these pluripotent germ cells develop into. The first are teratomas. Terato means monster, and oma is a tumor. So teratomas are monster tumors. And they're called that because they contain all different types of tissues, including hair, eyes, teeth, bone, and neurons. Kind of like a Frankenstein that's got bits of this and that stitched together. Now, there are 2 types of teratomas, and the first are mature cystic teratomas, which are the most common ovarian tumors in young women and are formed from tissue that comes from any of the 3 germ layers. One example is a struma ovarii tumor, which is made up of only thyroid tissue and can release thyroid hormone, which leads to hyperthyroidism. The other type are immature teratomas, and they develop specifically from neuroectoderm cells, which come from the ectoderm layer. Immature teratomas tend to be malignant and metastasize quickly. The second subtype is a yolk sac tumor, also called an endodermal sinus tumor, and it's made of germ cells that differentiate into yolk sac tissue. These are the most common germ cell tumors in children, and the tumors can be very aggressive. Under the microscope, they form Schiller-Duval bodies, which are rings of cells around a central blood vessel. The third subtype is a choriocarcinoma, and it's made of germ cells that turn into syncytiotrophoblaст cells, which are the ones that help form the placenta. These tumors are usually small, bleed easily, and often spread beyond the ovaries. The syncytiotrophoblaст cells secrete high levels of the hormone beta-human chorionic gonadotropin, and that can cause ovarian cysts to form. The fourth subtype is a dysgerminoma, and it's made of germ cells that turn into oocytes, which is actually the normal pattern, but then they start to grow uncontrollably. It turns out that these are the most common malignant types of ovarian tumors. Under the microscope, the germ cells have a central nuclei surrounded by a clear cytoplasm. So during ovulation, the follicle ruptures and releases an egg, which inadvertently leads to epithelial cell damage. To fix that damage, the epithelial cells have to undergo cell division to replace and heal the tissue. Each time cells divide, there's a chance of a mutation and the possibility of tumor formation. And this means that with more ovulatory cycles, there's an increased risk of tumor formation. So things that are associated with a decreased risk of ovarian cancer include things that reduce the number of ovulatory cycles, like pregnancy, breastfeeding, and oral contraceptive use. On the flip side, some things that are associated with an increased risk include certain medical conditions, like endometriosis and polycystic ovarian syndrome. There are also some genetic risk factors, like having the BRCA1 or BRCA2 mutation, which are both autosomal dominant mutations, which in addition to ovarian cancer carry with them an increased risk of breast cancer. There's also hereditary non-polyposis colorectal cancer, also known as Lynch syndrome, which increases the risk of developing a number of cancers, including ovarian cancer. Generally speaking, symptoms of ovarian cancers can be subtle and nonspecific. Common early symptoms can include abdominal distension, bloating, as well as abdominal or pelvic pain, which can come from an ovarian torsion, where the ovary gets twisted. Occasionally, ovarian tumors can cause ascites, abdominal masses, bowel obstruction, or dyspareunia, which is pain during sexual intercourse. A classic finding is a Sister Mary Joseph nodule, which happens when the cancer metastasizes to the umbilicus. This finding is often linked with a few types of cancer, one of which is ovarian cancer. Diagnosis of ovarian cancer typically involves looking for specific tumor markers like BHCG, as well as having a transvaginal ultrasound. Tumor biopsies are done to figure out whether a growth is benign or malignant, and imaging with a CT or MRI scan can be done to look for evidence of metastasis. Treatment of ovarian cancer typically involves chemotherapy, surgery, and sometimes radiotherapy. Surgery might be enough for malignant tumors confined to the ovary, whereas chemotherapy might be needed for diseases that spread. Carbohydrate antigen 125, called CA125, is a protein produced by various types of ovarian tumors. So tracking levels of this biomarker in the blood can help monitor response to therapy and potential relapse. Alright, as a quick recap, germ cell ovarian cancers come from pluripotent germ cells that normally develop into sperm or egg. The 4 major types of germ cell tumors are fetal teratomas, both mature cystic and immature teratomas, yolk sac tumors or endodermal sinus tumors, choriocarcinoma or placental tissue tumors, and finally dysgerminomas or oocyte tumors. A well-known risk factor for ovarian cancers is the cumulative amount of time a woman spends in ovulation, with protective factors being pregnancy, breastfeeding, and oral contraceptive use. Hey guys, what's happening? Thanks for watching that video on germ cell ovarian cancer. It was kind of like the end of a 3-part trilogy on ovarian cancer, so hopefully you found all those useful and you learned something from them. If you want to learn something more, you can always go check out osmosis.org, where we have a bunch of flashcards and quiz questions and videos and awesome scheduling tools and a bunch of awesome stuff, really. And also something of note is that we're coming out with a mobile app update really soon, so definitely be on the lookout for that if you're interested at all in osmosis.org things. So that should be really cool. I've seen it and it looks really nice. Other than that, thank you to Fiyang Pan for writing the script on that one. The editors, Rishi, Andrea, and Kyle with the script editing, and the video editor was Ifan, and I did the illustrating and the voiceover. So thank you to everyone who put all the work into those videos. I think they turned out really nice. Until next time, see you later.
Perinatal infections are a significant cause of impaired growth, developmental anomalies, and mortality. They can be divided into 2 categories. The first category is in utero infections, acquired transplacentally or through ruptured membranes, which lead to congenital defects. They're mostly represented by torch infections, an acronym that includes infections caused by toxoplasma, other agents, usually syphilis, rubella, cytomegalovirus, and herpes simplex virus. The second category belongs to intrapartum infections, which are acquired as the newborn passes through the birth canal, mostly caused by Group B streptococcus, hepatitis B virus, and HIV. Let's begin with torch infections. In some cases, intrauterine infection may be suspected on the basis of laboratory results obtained during pregnancy, like positive syphilis serology with increasing titers, and on ultrasonography findings. After birth, although most infections are asymptomatic, common early signs include fever, microcephaly, cataract, hearing loss, congenital heart disease, hepatosplenomegaly, thrombocytopenia, and jaundice. Late signs include vision loss, intellectual disability, deafness, and seizures. First, congenital toxoplasmosis is caused by the protozoan parasite Toxoplasma gondii. Prenatal diagnosis is based on ultrasonography signs of congenital infection, like ventriculomegaly, intracranial calcifications, and fetal growth restriction. It's then confirmed by polymerase chain reaction, or PCR testing, of amniotic fluid. If PCR doesn't confirm the presence of Toxoplasma DNA, those suspected of congenital toxoplasmosis will still need a complete diagnostic evaluation after birth. Postnatal diagnostic evaluation begins with a complete clinical examination. The most common early and late symptoms are cataract, microcephaly, hepatomegaly, jaundice, and purpura. Evaluation continues with serologic tests performed as soon as possible after birth. These consist of Toxoplasma immunoglobulin G plus Toxoplasma-specific immunoglobulin M and immunoglobulin A assays using peripheral blood. Also, neonatal Toxoplasma IgG antibodies should be tested in parallel with maternal Toxoplasma IgG antibodies to aid interpretation. Okay, so congenital infection is confirmed by positive IgG alongside positive IgM and IgA. If the individual has clinical findings suggestive of congenital infection, positive IgG, but negative IgM and IgA, they're presumed to be infected. This is because there might be a delay in IgM and IgA production. Repeat testing can help to exclude congenital toxoplasmosis if, in the absence of treatment, it shows a decline in IgG titer and negative Toxoplasma-specific IgM or IgA after 1 year of life. Next, if data is inconclusive, but there are clinical signs of congenital toxoplasmosis, a positive maternal history of infection, or if lab results came back positive, lumbar puncture is needed to obtain cerebral spinal fluid for Toxoplasma PCR, protein, glucose, and cell count. If PCR is positive, it confirms the diagnosis. Laboratory analysis of the cerebral spinal fluid might show elevated protein above 1 gram per deciliter or mononuclear pleocytosis. Okay, after that, brain CT is performed to look for focal brain lesions or hydrocephalus, which is characterized by an accumulation of cerebral spinal fluid within the brain. Other findings may include intracranial calcifications and cortical atrophy. An ophthalmological examination is also needed to look for chorioretinitis, which is the inflammation of the choroid and retina of the eye, as that might be the only sign of infection in newborns. If chorioretinitis, hydrocephalus, and intracranial calcifications were detected, this is highly suggestive of congenital toxoplasmosis. And finally, all newborns with suspected congenital toxoplasmosis should undergo hearing evaluation since it can lead to hearing loss. Prenatal management consists of spiramycin therapy in those under 18 weeks of gestation to prevent maternal transmission. Pyrimethamine and sulfonamides can be used later in gestation to treat the infected fetus. Newborn management consists of a regimen of 3 antiparasitic drugs. First, pyrimethamine is given in doses of 2 milligrams per kilogram orally once a day for 2 days, which is then reduced to 1 milligram per kilogram for 6 months. After 6 months, therapy is continued for another 6 months with a dose of 1 milligram per kilogram 3 times a week. Leucovorin is usually administered in doses of 10 milligrams 3 times a week for 1 year and a week, and sulfadiazine is given in doses of 50 milligrams per kilogram twice a day for just 1 year. Glucocorticoids like prednisone 0.5 milligrams twice per day are added if the cerebral spinal fluid protein is above 1 gram per deciliter or when chorioretinitis causes vision problems. Next, congenital syphilis is caused by the spirochete Treponema pallidum. Prenatal diagnosis is based on ultrasonography findings and on the same test as in postnatal diagnosis, but using umbilical cord samples. After birth, evaluation begins with a complete physical examination. Clinical findings can be divided arbitrarily into early signs, which appear under or around 2 years of age, and late, which appear after 2 years of age. More specific early signs might include a large, thick, and pale placenta, generalized non-tender lymphadenopathy, bone deformities, and rhinitis. A maculopapular rash consisting of small red or pink spots also might appear 1 to 2 weeks after rhinitis. The rash progresses over 1 to 3 weeks, and it's followed by desquamation and crusting. If present at birth, it may be widely disseminated and bullous. The umbilical cord might be edematous and resemble a barber's pole, with spiral stripes of red and light blue alternating with white discoloration. Long bone abnormalities associated with pathologic fractures or pain giving the appearance of paralysis might be present as well. Regarding late signs, they can develop anywhere, including the face, represented by frontal bossing where the forehead is really prominent, saddle nose, or short maxilla. The eyes, where syphilis manifests as interstitial keratitis, secondary glaucoma, and corneal scarring. The ears, where it leads to hearing loss, and oral pharynx, presenting as the Hutchinson triad, which is virtually pathognomonic for congenital syphilis. The triad consists of Hutchinson teeth, which are small, notched, widely spaced permanent teeth, mulberry molars, described as molars with small cusps and enamel nodules, and perforation of the hard palate. Next, diagnosis can be confirmed by detecting spirochetes on dark field microscopy or by PCR using samples from any mucosal lesion the newborn or the placenta might present. If positive, diagnosis can be made. Now, if negative, serologic tests are needed. First, non-treponemal tests like rapid plasma reagent, or RPR, which are based on the reactivity of the infected serum to a cardiolipin cholesterol lecithin antigen, can be ordered. If any non-treponemal serum test shows an antibody titer 4 times higher than the maternal titer value, alongside any typical symptom of congenital syphilis, infection is highly probable. If the titers are normal or lower, but the individual has typical clinical manifestations, syphilis is considered unlikely. In neonates with no signs of illness or low or negative serologic titers, syphilis is considered possible. Second, treponemal tests like fluorescent treponemal antibody absorption, or FTABS, which detect antibodies against specific treponemal antigens, are required to confirm any positive non-treponemal test result. Next, those with clinical signs of congenital syphilis or born of infected mothers who received inadequate or no treatment should undergo subsequent testing, including long bone radiographic examination and lumbar puncture for cell count, protein, and non-treponemal tests. Treatment under 1 month of age consists of a single dose of penicillin G benzathine, 50,000 units per kilogram, intramuscularly. Those over 1 month of age require 50,000 units per kilogram of penicillin G benzathine intravenously every 4 to 6 hours for 10 days. Third is congenital rubella infection, which leads to congenital rubella syndrome in the newborn. The prenatal diagnosis is based on specific findings on ultrasonography and positive rubella-specific IgM testing. After birth, evaluation begins with a clinical exam. Common early signs include meningoencephalitis, large anterior fontanelle, cloudy cornea, cataract, glaucoma, and retinopathy. Common late signs include congenital heart defects like patent ductus arteriosus, endocrine disorders like diabetes, thyroid disease, and growth hormone deficiency, and immune defects. Congenital rubella syndrome can be confirmed, infection only, or probable, depending upon clinical findings and laboratory findings. Evaluation begins with serologic tests. A high level of rubella-specific IgM antibody in those under 6 months of age, or IgG in those between 6 and 12 months of age, which persists for a longer time than expected from passive transfer of maternal antibody, confirms diagnosis. Next, viral detection using viral isolation from cultures based on nasopharyngeal secretions, or PCR, can be used instead of or together with serologic tests to confirm the diagnosis. Other tests include a complete blood count with differential, lumbar puncture and cerebrospinal fluid analysis, and X-ray examination for bone anomalies. Thorough ophthalmologic and cardiac evaluations are also useful in detecting associated congenital defects. In those with symptoms consistent with CRS and negative serologic testing or viral detection, CRS is probable. Treatment is mostly symptomatic. This means prevention is vital. Those who are planning on becoming pregnant should be vaccinated at least 28 days beforehand because the vaccine is a live virus. Okay, so congenital cytomegalovirus infection is diagnosed prenatally by viral culture, cytomegalovirus detection on PCR, or by cytomegalovirus-specific IgM antibody measurement in all those who are symptomatic on ultrasonography. Findings on ultrasound consist mostly of periventricular calcifications, ventriculomegaly, microcephaly, fetal growth restriction, and ascites or pleural effusion. After birth, clinical examination usually reveals petechiae, jaundice, hearing loss, chorioretinitis, and seizures. Cataracts and other severe eye problems are not typically found in congenital cytomegaloinfection. If these are present, they strongly suggest another cause. Next, laboratory diagnosis begins with PCR or viral isolation from cultures using urine samples collected within the first 3 weeks of life. If these come back positive, diagnosis can be confirmed. If inconclusive, repeat viral culture or PCR testing is required. If positive and the infant is under 3 weeks of age, diagnosis can be made. Alternatively, if the results are positive in a symptomatic infant older than 3 weeks, this suggests but does not confirm congenital cytomegaloinfection because of the possibility of postnatal infection. The only way to confirm is retrospectively by PCR analysis of dried blood samples or the so-called Guthrie cards obtained for newborn screening. If PCR comes back negative, the infection was acquired after birth. Other lab tests are ordered to assess the extent of the infection. These include a liver panel, which might show elevated liver transaminases, a full blood count revealing thrombocytopenia, and lumbar puncture with cerebrospinal fluid analysis, which may reveal elevated protein. Neuroimaging consists mostly of ultrasonography, unenhanced CT, or MRI, which might detect intracranial calcifications, lenticulostriate vasculopathy, and white matter disease. Treatment of symptomatic individuals includes intravenous ganciclovir, usually 6 mg per kilogram every 12 hours. After 6 weeks, they can switch to oral valganciclovir, 16 mg per kilogram every 12 hours, for a total of 6 months. And finally, neonatal herpes simplex virus infection is mostly acquired during birth. Congenital infection is possible too. Prenatal diagnosis is based on specific ultrasonography findings and positive viral cultures or PCR. After birth, diagnosis begins with a complete clinical examination. In utero infection usually results in a characteristic triad of skin vesicles, ulceration or scarring, eye damage, and severe central nervous system manifestations, including microcephaly or hydranencephaly. When it develops after birth, the infection usually presents as one of 3 patterns, which occur with roughly equal frequency: localized to the skin, eyes, and mouth, localized central nervous system disease, and disseminated disease involving multiple organs. One specific sign which may or may not appear are the characteristic vesicular skin lesions. Next, lab tests needed for diagnosis include PCR, viral culture, and detection of viral antigens using rapid direct immunofluorescence assays, which is not very specific or helpful. Swab specimens have to be collected from the blood, conjunctivae, mouth, nasopharynx, rectum, any skin lesion, and cerebrospinal fluid. If all or most swabs are positive, diagnosis can be made. Similarly, in infants with symptoms of herpes infection and negative viral culture or PCR in all of the specimens, infection is unlikely, but it can't be excluded. Regarding treatment, acyclovir, 60 mg per kilogram intravenously divided every 8 hours, should be initiated in all suspected cases while awaiting confirmatory diagnostic tests. If the infection is localized, 14 days of treatment are enough. If it's disseminated, it should last for a minimum of 21 days. Vigorous supportive therapy is required, including appropriate IV fluids, alimentation, respiratory support, correction of clotting abnormalities, and control of seizures. Let's switch gears and talk about intrapartum infections, which are also mostly asymptomatic. Their symptoms, when present, tend to be nonspecific and include vomiting or poor feeding, increased sleepiness or lethargy, fever or hypothermia, tachypnea, rashes, diarrhea, and abdominal distension. Okay, so first up is Group B streptococcus infection, which is caused by Group B streptococcus, also called GBS or Streptococcus agalactiae. There are 3 types of GBS infection in neonates. Early onset GBS presents within 24 hours of birth as sepsis without a focus, leading to nonspecific signs like irritability, lethargy, tachypnea, hypoxia, temperature instability, and hypotension. Fever is usually absent. It can also present as pneumonia when it leads to symptoms like tachypnea, grunting, hypoxia, and increased work of breathing. Late onset GBS usually occurs at 4 to 5 weeks of age. It often presents as bacteremia without a focus with fever above 38 degrees or as meningitis, causing symptoms like seizures, temperature instability, irritability or lethargy, bulging fontanelle, or neck stiffness. Late onset GBS occurs in infants older than 3 months of age. It typically manifests as bacteremia without a focus, even though the central nervous system, soft tissues, bones, and joints might be detected as sources of bacterial dissemination. Now, the biggest concern in GBS infection is sepsis. The signs of neonatal sepsis are subtle and nonspecific, so assessing for risk factors are vital in detecting it. Risk factors for sepsis include maternal intraamniotic infections, inadequate maternal intrapartum antibiotic prophylaxis, preterm delivery, and prolonged duration of rupture of membranes. These factors, alongside any relevant clinical sign the infant might present, raise suspicion of sepsis, which is then confirmed by a series of lab tests. If there are no risk factors, observation only might be enough. If there's at least one risk factor, further evaluation is needed. First, cultures of blood and any other infected site like the bone or joint are needed to identify GBS. Next, complete blood count with differential is needed, and it usually shows an increased white blood cell count, though an elevated WBC count is not specific to infection. Next, if these tests detect either the bacteria or signs of inflammation, or alternatively, if there's any sign of sepsis, lumbar puncture for cerebrospinal fluid cell count, protein and glucose concentration, gram stain and culture is also required to further assess the presence of bacteria in normally sterile sites. Subsequently, if respiratory symptoms are present, chest radiography might detect GBS pneumonia by showing a diffuse alveolar pattern and pleural effusions. And finally, urine culture by urinary catheter or suprapubic aspirate is included in the sepsis evaluation if the infant is older than 6 days of age. Now, if bone or joint involvement is suspected, radiographs of the involved site, magnetic resonance imaging, and bone biopsy may be necessary. Regarding treatment, supportive care includes ventilator support, recognition and treatment of shock, addressing any fluid and electrolyte imbalance, and management of seizures. Empirical antimicrobial therapy for sepsis usually includes a combination of ampicillin and gentamicin. For early onset infection, ampicillin 50 mg per kilogram every 12 hours and gentamicin 5 mg per kilogram every 36 hours are given intravenously for 10 days. For late onset, cefotaxime can also be added to the regimen. Once the bacteria is identified, early onset infection is treated with penicillin G, 250,000 to 450,000 units per kilogram per day, divided every 8 hours. And for late onset infection, the dose rises to 450,000 to 500,000 units per kilogram, divided every 6 hours. Prevention can be achieved by screening pregnant individuals for GBS colonization and by giving antibiotics during labor if they have a positive GBS screen. Next, in neonatal hepatitis B infection, newborns usually remain asymptomatic. Symptomatic infection usually causes jaundice, lethargy, failure to thrive, abdominal distension, and pale stools. Occasionally, it might lead to hepatomegaly, ascites, and hyperbilirubinemia, and extremely rarely, the disease is fulminant and even fatal. Diagnosis is based on serological assays, more specifically on the presence of hepatitis B surface antigen, hepatitis B envelope antigen, and of anti-hepatitis B surface antigen and anti-hepatitis B core antigen antibodies by 1 to 2 months of age. With sensitive assays, hepatitis B surface antigen can be detected in the blood within 1 to 2 weeks of exposure, despite the fact that clinical disease, if it appears, does so around 2 months after exposure. Hepatitis B envelope antigen can be detected later in the incubation period, so if serology is negative, then there's no infection. If just hepatitis B surface antigen is present, then infection is in its early phase. And finally, if just the anti-hepatitis B surface antibody is present, it means there's no infection and it suggests the response to the hepatitis B vaccine. Other initial tests include complete blood count with platelets, liver panel, alpha-fetoprotein levels, and liver ultrasonography to assess the extent of the liver involvement. Regarding treatment, there is no specific therapy for neonatal hepatitis B infection, since antiviral therapies have not been tested in this age group. Management usually involves monitoring by laboratory evaluation that includes liver enzyme testing and hepatitis B serology, symptomatic care, inadequate nutrition. In the rare infant with fulminant hepatitis B, off-label use of nucleoside analogs like entecavir and tenofovir may be considered. Prevention can be achieved by providing those born of hepatitis B surface antigen positive mothers with hepatitis B immunoglobulin, 0.5 milliliters intramuscularly, and monovalent hepatitis B vaccine within 12 hours of birth, with subsequent vaccine doses at 1 to 2 and 6 months of age. And finally, there's HIV infection, which is mostly caused by retrovirus human immunodeficiency virus type 1. Now, early HIV infection in newborns doesn't lead to any clinical signs that might raise concern. Later on, manifestations include generalized lymphadenopathy, hepatomegaly, splenomegaly, failure to thrive, oral candidiasis, developmental delay, recurrent bacteremia, opportunistic infections, and hepatitis. Diagnosis in neonates is usually based on serology findings. However, in newborns, antibody assays commonly used for HIV testing in adults and older children are not reliable. This is because transplacentally acquired maternal antibody caused false positive results. So diagnosis is made by HIV virologic testing using assays that detect HIV deoxyribonucleic acid, or DNA, or ribonucleic acid, or RNA. Now, serial testing is required, and the timing of testing depends upon whether the infant is categorized as low or higher risk. Okay, so those born to HIV-infected individuals who received antiretroviral therapy during pregnancy with HIV RNA levels below the lower limit of detection of an ultrasensitive assay and with no concerns related to adherence to treatment are considered low risk. This means testing is performed at 2 to 3 weeks, 4 to 8 weeks, and 4 to 6 months of age. Higher risk infants are considered those born to HIV-infected individuals who did not receive standard of care for HIV during pregnancy. In this group, testing should be performed at birth, 2 to 3 weeks, 4 to 6 weeks, 8 weeks, and 4 to 6 months of age. A positive result at any point should be confirmed as soon as possible with a repeat virologic test. Diagnosis is confirmed when at least 2 virologic tests from different blood samples are positive. Presumptive exclusion of HIV infection in non-breastfed infants is based on 2 negative virologic tests, one obtained after the age of 14 days and one after the age of 4 weeks, or 1 negative virologic test after the age of 8 weeks. Definitive exclusion of HIV infection in non-breastfed infants is based on 2 or more negative virologic tests, one obtained after 1 month of age and one after 4 months of age, or alternatively, 2 negative antibody tests from separate specimens obtained after 6 months of age. For both presumptive and definitive exclusion of HIV infection, there must be no other clinical or laboratory evidence of infection, including no positive virologic test results or low CD4 T lymphocyte cell count. Okay, so once infection is diagnosed, other tests are necessary. Both measurements of CD4 positive and CD8 positive T cell populations and plasma viral RNA concentration or viral load assessments are required to determine the degree of illness, prognosis, and the effects of therapy. Initially, CD4 positive counts may be normal but eventually fall if the individuals are left untreated. CD8 positive counts usually increase initially and do not fall until late in the infection. These changes in cell populations result in a decrease in the CD4 positive to CD8 positive cell ratio, which is characteristic of HIV infection. Plasma viral RNA concentrations in untreated individuals under 12 months are typically high, around 200,000 RNA copies per milliliter. Management consists of a combination of 3 antiretroviral drugs, which most commonly include 2 nucleoside reverse transcriptase inhibitors, plus either a protease inhibitor or an integrase strand transfer inhibitor. Okay, quick recap. First, congenital toxoplasmosis is diagnosed prenatally by ultrasound and PCR. After birth, it's confirmed by positive toxoplasma-specific IgG, IgM, and IgA assays. Prenatal management consists of spiramycin, pyrimethamine, and sulfonamides. Newborn management consists of a regimen of 3 antiparasitic drugs, pyrimethamine, leucovorin, and sulfadiazine, for roughly 1 year. Next, congenital syphilis can be confirmed by detecting spirochetes on dark-field microscopy or by PCR using samples from any mucosal lesion the newborn or the placenta might present. In most cases, both treponemal and non-treponemal tests are also needed. Treatment under 1 month of age consists of intramuscular penicillin G benzathine and over 1 month of age of intravenous penicillin G benzathine. Congenital rubella infection is diagnosed prenatally based on specific findings on ultrasonography and positive rubella-specific IgM testing. After birth, it's confirmed by positive rubella-specific IgM antibody in those under 6 months of age or IgG in those between 6 and 12 months of age, which persist for a longer time than expected from passive transfer of maternal antibody. Viral isolation from cultures of nasopharyngeal secretions or PCR can be used instead of or together with serologic tests to confirm the diagnosis. Treatment is mostly symptomatic. Okay, so congenital cytomegalovirus infection is diagnosed prenatally by viral culture, cytomegalovirus DNA detection on PCR, or by cytomegalovirus-specific IgM antibody measurement in all those who are symptomatic on ultrasonography. After birth, diagnosis is confirmed by PCR or viral isolation from cultures using urine samples in those under 3 weeks of age. Alternatively, if the results are positive in a symptomatic infant older than 3 weeks, PCR analysis of the Guthrie cards is needed to confirm the diagnosis. If PCR comes back negative, the infection was acquired after birth. Those who are symptomatic can be treated with intravenous ganciclovir for a total of 6 months. Neonatal herpes simplex virus infection is diagnosed before birth based on specific ultrasonography findings and positive viral cultures or PCR. After birth, swab specimens have to be collected from the blood, conjunctivae, mouth, nasopharynx, rectum, any skin lesion, and cerebrospinal fluid. If all or most swabs are positive, diagnosis can be made. Regarding treatment, acyclovir should be initiated in all suspected cases while awaiting confirmatory diagnostic tests. Next, in Group B streptococcus infection, diagnosis begins with sepsis risk factors assessments. Then, cultures of blood and any other infected site, including cerebrospinal fluid, are needed to identify GBS. Also, complete blood count with differential usually shows an increased white blood cell count. If other sites of infection are suspected, subsequent testing is required. Empirical antimicrobial therapy for sepsis usually includes a combination of ampicillin and gentamicin. Once the bacteria is identified, infection is treated with penicillin G. Neonatal hepatitis B infection is diagnosed by serological assays, more specifically on the presence of hepatitis B surface antigen, hepatitis B envelope antigen, and of anti-hepatitis B surface antigen and anti-hepatitis B core antigen antibodies by 1 to 2 months of age. So if serology is negative, then there's no infection. If just hepatitis B surface antigen is present, then infection is in its early phase. And finally, if just the anti-hepatitis B surface antibody is present, it means there is no infection but a response to the hepatitis B vaccine. Management usually involves monitoring, symptomatic care, and adequate nutrition. Prevention can be achieved by vaccination. And finally, there's HIV infection, which is confirmed when at least 2 virologic tests from different blood samples are positive. Both measurements of CD4 positive and CD8 positive T-cell populations and plasma viral RNA concentration or viral load assessments are required to help determine the degree of illness, prognosis, and the effects of therapy. Management consists of a combination of 3 antiretroviral drugs, which commonly include 2 nucleoside reverse transcriptase inhibitors, plus either a protease inhibitor or an integrase strand transfer inhibitor.
Congenital cytomegalovirus infection is the infection of a fetus with cytomegalovirus, or CMV, during intrauterine life. CMV is among the most common infections that cause defects during fetal development. It is often grouped with other bacteria, parasites, and viruses that cause similar illnesses in the newborn, known under the acronym TORCH, which includes toxoplasma, other pathogens, usually syphilis, rubella, cytomegalovirus, and herpes simplex virus. CMV belongs to the herpes viridae family of viruses. Herpes viruses are double-stranded DNA viruses which are surrounded by a lipid envelope. CMV is usually transmitted through contact with blood and other bodily fluids like breast milk, saliva, genital secretions, and urine of an infected person, or from transplanted organs. Congenital CMV infection occurs when a pregnant woman is infected by CMV for the first time during the pregnancy, or there's reactivation of an old infection, or reinfection with a new strain of CMV. The virus in the mother travels through the placenta to the growing fetus. The exact mechanism by which CMV causes infection and defects in the developing fetus is still unknown, but it's thought to be because of 2 things. First, CMV can be cytopathic, or cell-damaging, as it replicates within the cells. It breaks down the cytoskeletons, which maintain the cell structure, which results in enlarged cells with intranuclear viral inclusion bodies, giving it the classic owl's eye appearance. It is also possible CMV slows down the process of mitosis, or cell division. Since mitosis helps drive the development of the fetus, tissue with infected cells might not grow properly. Second, CMV invades the endothelium of blood vessels, resulting in vasculitis, or inflammation of blood vessels. Vasculitis can affect placental as well as fetal blood vessels, causing narrowing of the vessel wall. And, as a result, not enough blood flows to developing organs, causing abnormalities. Congenital CMV also increases the risk of intrauterine growth restriction, meaning the fetus does not grow well, or oligohydramnios, or polyhydramnios, which is increased or decreased amniotic fluid. Most congenital CMV infections are asymptomatic or silent, with only 1 in 10 infected infants showing symptoms at birth. The most common clinical manifestations include petechiae, which is tiny purple, red, or brown spots on the skin, jaundice, when the skin, whites of the eyes, and mucous membranes turn yellow, hepatosplenomegaly, which is enlarged liver and spleen, and microcephaly, or an abnormally small head size due to an underdeveloped brain. The hallmark feature of congenital CMV is progressive, permanent sensory neural hearing loss, or deafness, which can present at birth or develop later in life. Congenital CMV is also associated with eye abnormalities such as chorioretinitis, or inflammation of the choroid and retina, strabismus, or muscle imbalance of the eyes, or cortical vision impairment. CMV also can cause intellectual disability, developmental delays, behavioral disorders, motor disabilities, and seizures. The diagnosis of congenital CMV infection can be made prenatally, before birth, or postnatally, after birth. Prenatal testing includes ultrasonography of the fetus to detect developmental anomalies, amniocentesis to obtain amniotic fluid for viral culture, or CMV-PCR, or fetal blood sampling for CMV-PCR, or cytomegalovirus-specific IgM antibody measurement. After birth, diagnosis is confirmed by PCR, or viral isolation from urine or saliva samples in newborns obtained under 3 weeks of age. A full physical examination of the baby should be done, looking for skin rashes, enlarged liver and spleen, and microcephaly. In addition, babies with congenital CMV should be screened for hearing loss at birth, and periodically during childhood and adolescence. Some hospitals will screen all babies for CMV who fail their newborn hearing screening, because CMV can cause congenital hearing loss. Other tests done to assess the extent of the infection may include a liver panel, which might show elevated liver transaminases or elevated bilirubin levels, a full blood count revealing thrombocytopenia, or low platelets. Neuroimaging of the brain by ultrasonography, unenhanced CT or MRI may be done, which might detect intracranial calcifications, enlarged ventricles, polymicrogyria, lenticulostriate vasculopathy, or white matter disease. Treatment is usually reserved for symptomatic infants and includes antiviral medications like ganciclovir and valganciclovir, usually given for a total of 6 months. The antiviral medication has been shown to reduce the risk of hearing loss progressing and improves head size growth and developmental milestones early in life. It does not reverse the damage that's already occurred. Other supportive measures, such as blood products and platelet transfusions, can be given. As the child grows, functional therapies such as physical therapy, occupational therapy, and speech or language therapies and vision therapies may also be needed. Children with hearing loss may be taught sign language, be fitted for hearing aids, or undergo cochlear implant procedures. Prevention of congenital CMV by vaccine, like what is routinely done to prevent congenital rubella, is not currently available. Women who wish to reduce their risk of CMV infection during pregnancy should reduce or avoid contact with saliva and urine from toddlers and young children, who are often asymptomatically shedding CMV and may be a source of infection. Alright, as a quick recap. Congenital CMV infection occurs when a pregnant woman infected with CMV passes it on to her growing fetus, which results in fetal infection, and may, but not always, result in birth defects. Fetal defects caused by CMV are thought to be caused by a combination of cytopathic effect on fetal cells and blood vessel injury leading to decreased blood flow to the developing organs. Clinical manifestations include petechiae, jaundice, hepatosplenomegaly, sensory neural hearing loss, eye abnormalities, microcephaly, intellectual disability, developmental delays, behavioral disorders, motor disabilities such as cerebral palsy, and seizures. Treatment in the symptomatic newborn and young infant involves antiviral medications like ganciclovir and valganciclovir for a total of 6 months. Long-term treatment involves therapies to improve milestones, mobility, hearing, speech, and language. A CMV vaccine is not available, but reducing contact with saliva and urine during pregnancy may be helpful to reduce CMV transmission.
Fetal alcohol syndrome, or FAS, occurs because of maternal use of alcohol during pregnancy. It's currently the leading cause of intellectual disability in the US and can cause characteristic physical abnormalities. Normally, the fetus is connected to the placenta by the umbilical cord, so the fetus gets oxygen and nutrients from the mother. Unfortunately, ethanol and toxic alcohol metabolites, like acetaldehyde, also pass freely through the placenta, but the fetal liver doesn't have the necessary enzymes to metabolize them, so they build up inside the fetus really fast. In FAS, ethanol interferes with cell division and proliferation, cell growth and differentiation, and with the migration of mature cells to their final location in the developing embryo, which affects the development of various fetal tissues, including the brain. Alcohol-induced brain damage includes partial or complete agenesis of the corpus callosum, which links the two hemispheres together, so it either forms incompletely or not at all. This causes intellectual disability and seizures. When the frontal cortex and the hippocampus are affected, this causes poor memory and communication skills, as well as intellectual disability. The cerebellum can also be smaller in size, called cerebellar hypoplasia, leading to trouble with movement and balance. The most common symptom of FAS is growth retardation, resulting in low height and weight. Microcephaly can also occur, which results from an overall decrease in brain growth. Children with FAS may also have certain facial characteristics, like small palpebral fissures, which is a reduced distance between the two sides of an eye, smooth or flat philtrum, and a thin vermilion border, which is the border of the lip. Other features include limb dislocation and heart defects. Now, there's no specific blood test or brain scan to detect FAS, and the disorder is suspected based on characteristic symptoms and maternal history of alcohol consumption during pregnancy. Unfortunately, in individuals with FAS, brain damage due to ethanol toxicity is permanent, so treatment focuses on the management of the symptoms of the disease through personalized educational programs for children with trouble learning, behavioral interventions for children with difficulties in communication, and anti-seizure medications. Alright, as a quick recap, fetal alcohol syndrome is when the fetus is affected by maternal alcohol consumption during pregnancy. It's characterized by the presence of physical abnormalities like growth retardation, intellectual disability, and craniofacial defects. Additional findings include limb dislocation and heart defects. Treatment is focused on the management of symptoms. Cervical cancer arises in the cervix, most frequently at the transformation zone, which is where the glandular epithelium of the endocervix meets the squamous epithelium of the exocervix. The most frequent type of cervical cancer is squamous carcinoma, and it's almost always due to human papillomavirus, or HPV. HPV strands 16 and 18 account for most cases, and strains 31, 33, 45, 52, and 58 account for the rest. However, it can take up to 2 decades for HPV infection to progress through precancerous lesions of increasing severity and finally to cancer. So there are 2 key elements that make cervical cancer unique among cancers. First, vaccinating against high-risk HPV strains can help prevent cervical cancer. Second, a pap smear can be done to screen for precancerous lesions. And if they're found, it's possible to remove the precancerous lesions before they progress to cancer. As a result, cervical cancer is one of the most preventable gynecologic malignancies. Cervical cancer screening is the cornerstone of prevention and should be done in both vaccinated and unvaccinated females between the ages of 21 to 65, with regular pap tests. With the pap test, a thin, long brush is used to scrape cervical cells off the cervix. The test takes about 2 minutes, but it can cause slight discomfort as well as light spotting afterwards. A normal pap test is when microscopy shows no cervical cell abnormalities, and when that's the result, screening can be repeated in 3 years. Cervical cell abnormalities can show up as either atypical squamous cells, or ASC, or cervical squamous intraepithelial lesions, or CSIL. Atypical squamous cells look mildly atypical and don't necessarily develop into cervical cancer, whereas cervical squamous intraepithelial lesions are full-blown dysplastic and have a greater chance of becoming cervical cancer. ASC results can further be classified as either ASC-US, where US stands for unknown significance, and there are no high-grade intraepithelial lesions, or ASC-H, which is when there may be a high-grade intraepithelial lesion and further testing is recommended. Now, there can be either low-grade squamous intraepithelial lesions, or LSIL, or high-grade squamous intraepithelial lesions, or HSIL, depending on how dysplastic the cells look. Management of abnormal pap smear findings depends on the age of the individual. In females 25 or older, an ASC-US or LSIL result warrants a reflex HPV test. That's where a sample of fluid from the pap test is used to look for HPV DNA. If this test comes back negative, the female should get another pap smear and HPV test in 3 years. On the other hand, if the initial reflex HPV test comes back positive, a colposcopy should be done. Alternatively, instead of doing the reflex HPV test from the get-go, the pap test can be repeated in 1 year, and if it comes back negative, the female can go back to routine screening. If the pap test at 12 months shows any kind of abnormality, a colposcopy should be done. Now, a colposcopy is done with a magnifying device called a colposcope to get a zoomed-in view of the cervix as well as to obtain biopsies. To better highlight abnormal cells, different solutions, like 3 to 5% acetic acid, or dilute Lugol solution may be applied, which will cause abnormal cells to change color. During colposcopy, biopsy should be obtained from the transformation zone, and from any other suspicious-looking areas, like those that become white after acetic acid staining. The biopsy is examined under a microscope to look for cervical intraepithelial neoplasia, or CIN for short, which comes in 3 grades. With CIN1, there are abnormal-looking cells only in the deep third of the epithelium. With CIN2, the abnormal cells make up approximately 2/3 of the epithelium. And with CIN3, abnormal cells make up more than 2/3 of the epithelium. Finally, the biopsy can come back as either carcinoma in situ, which is when the entire epithelium is made up of abnormal cells, but they don't make it past the basement membrane, or invasive cervical cancer, when the abnormal cells have made it past the basement membrane. Now, if the colposcopy shows no CIN or CIN1, options include follow-up without treatment or a diagnostic excisional procedure. For follow-up, another pap smear and an HPV test should be done in 12 months. If both of those come back negative, another pap smear and HPV test should be done in 3 years. And if both are negative again, the individual can go back to routine testing. If any tests come back abnormal during follow-up, the colposcopy should be repeated. If CIN1 persists for more than 2 years, a diagnostic excisional procedure can be done. Diagnostic excisional procedures include loop electrosurgical excision procedure, which is when a wire loop heated with electrical current is used to remove suspicious-looking cervical tissue, and a cold knife conization, which is when a cone-shaped section of cervical tissue that contains the abnormal cells is removed. These come with the downside that they may cause cervical incompetence in future pregnancies, which means that the cervix doesn't stay shut like it normally would to seal the uterine cavity. If the biopsy results come back as CIN2 or CIN3, treatment can be done through loop electrosurgical excision, laser excision, or laser ablation of the cervical transformation zone. Then, follow-up involves a pap smear and a reflex HPV test at 12 and 24 months, and after 2 normal results, the female can go back to routine testing every 3 years. If any test comes back abnormal during follow-up, a colposcopy should be done, as well as endocervical sampling, which is when biopsies are taken from the endocervical canal. Now, after an abnormal pap smear with an ASCH or HSIL result in females 25 years or older, usually warrants a colposcopy or diagnostic excisional procedures. If the colposcopy shows CIN1, options include repeating the pap smear and HPV test at 12 and 24 months. And if both tests come back negative both times, the female can go back to routine testing. If the test comes back abnormal at least once during this follow-up, a colposcopy should be performed. And, in particular, if any pap test during follow-up shows an HSIL result again, a diagnostic excisional procedure should be done. Alternatively, a diagnostic excisional procedure can be done from the start. If the colposcopy done for an ASCH or HSIL result shows CIN2 or CIN3, electrosurgical excision, laser excision, or laser ablation of the cervical transformation zone can be done. Okay, now in females aged 21 to 24, things are handled slightly differently. That's because in young females, an ASCUS or LSIL result doesn't necessarily mean HPV infection or high risk of cervical cancer. And even if there is an HPV infection, the immune system may clear it, and these abnormalities may go away on their own within 24 months. So, for an ASCUS or LSIL result in young females, the recommendation is to repeat the pap test in 12 months instead of 3 years. If the second pap test comes back negative, or shows ASCUS or LSIL again, a third pap test should be done another 12 months later, so 24 months after the first abnormal result. If the third test comes back negative, repeat a fourth pap test again in 12 months, and once 2 tests in a row come back normal, the female can go back to routine screening once every 3 years. Alternatively, for ASCUS results, a reflex HPV test can be done. If reflex HPV testing shows no HPV, the female can go back to routine screening once every 3 years. With a positive reflex HPV test, management is still to perform a second pap test in 12 months instead of 3 years, with the goal of getting 2 consecutive normal results at 12-month intervals. Okay, now still in the 21 to 24 age group. If the initial pap test or the second pap test, the one done after 12 months, comes back as ASCH or HSIL, or if the third pap test, the one at 24 months, shows any kind of abnormal result, including ASCUS, a colposcopy is recommended. If the colposcopy shows no CIN or CIN1, follow-up involves getting a pap smear and a colposcopy every 6 months for the next 2 years. If the 2 pap smears come back negative for cell abnormalities, and there is still no CIN2 or CIN3 on colposcopy, then the female can go back to routine screening with pap tests once every 3 years. If the pap test comes back as HSIL, or the colposcopy results show CIN2 or 3 for 1 year, treatment should be done either through loop electrosurgical excision, laser excision, or laser ablation of the cervical transformation zone. If, on the other hand, the colposcopy comes back as CIN2 or CIN3 from the start, both observation and immediate treatment can be options. Usually, observation is preferred for CIN2, and it involves getting a pap smear and a colposcopy every 6 months for 12 months. If both tests are negative both times, a pap smear and an HPV test should be done 12 months later. If that test comes back negative, it can be repeated 3 years later. And if it's once again negative, the female can go back to routine screening. If either the pap smear or the HPV test done at 2 years or 5 years comes back abnormal, another colposcopy should be done. Treatment, on the other hand, is preferred for CIN2 lasting more than 24 months, and CIN3 from the start. And it can be done either through loop electrosurgical excision, laser excision, or laser ablation of the cervical transformation zone. Generally speaking, with appropriate screening, cervical intraepithelial neoplasia can be caught and removed before it even becomes cervical cancer. If it's not caught early, however, cervical cancer can progress without any symptoms for a long period of time. Eventually, symptoms can appear like irregular vaginal bleeding or postcoital bleeding. On a pelvic examination, there may be a lesion suggestive of cervical cancer, which may look like an ulceration or mass. If a tumor develops inside the endocervical canal, there may be an enlarged, indurated cervix with a smooth surface, referred to as a barrel-shaped cervix. Any visible lesion should be biopsied, and any cervix that is unusually firm or expanded should be sampled with biopsies and endocervical curettage, even if there's no evidence of neoplasia on a pap smear. Heavy bleeding is a major risk when biopsying visible cervical lesions, so hemostatic agents like Monsil solution should be used if needed. The biopsy can come back either as carcinoma in situ or invasive cervical cancer. Carcinoma in situ is considered stage 0 cervical cancer and can be treated with an excisional procedure, cold knife conization, or loop electrosurgical excision procedure. For invasive cervical cancer, a CT or MRI can be done for further staging. Stage 1 cervical cancer is strictly confined to the cervix and the uterine corpus, and can be broken down further in 1A and 1B. 1A is when the cancer can only be seen under the microscope and has invaded less than 5 millimeters into the cervical stroma. And 1B can sometimes be seen with the naked eye, and is when cancer has invaded more than 5 millimeters into the cervical stroma. Stage 2 cervical cancer has spread beyond the uterus, but hasn't reached the lower third of the vagina or the pelvic wall, and can also be 2A or 2B. 2A cervical cancer is limited to the upper 2/3 of the vagina, but the perimetrium, which is a layer of connective tissue that separates the uterus and cervix from the urinary bladder, isn't affected. 2B cervical cancer has invaded the perimetrium, but hasn't spread to the pelvic wall. Stage 3 cervical cancer has 3 substages depending on involvement. Stage 3A has spread to the lower third of the vagina, but hasn't reached the pelvic wall. Stage 3B has spread to the pelvic wall or has invaded the ureters, causing hydronephrosis, or urine buildup in the kidneys. And stage 3C has spread to the pelvic or para-aortic lymph nodes. Finally, with stage 4 cervical cancer, the cancer has either spread to adjacent pelvic organs, like the bladder or rectum, in which case it's 4A, or has spread to distant organs, in which case it's 4B. Now, usually, stage 1 cervical cancer is discovered following a pap smear. And the good news is, for females with stage 1A cervical cancer who wish to bear children in the future, cold knife conization can be done to remove the cancer, and the uterus is left in place. Or a trachelectomy can be done, which is when just the cervix and the upper third of the vagina is removed. With cold knife conization, a histopathological examination should be performed to see if the edges of the removed piece have any cancer cells. If they do, the conization can be repeated, or a radical trachelectomy can be done, with the latter being preferred if the cancer has invaded into blood or lymph vessels. Alternatively, if the female with stage 1A cervical cancer doesn't want to preserve fertility, a total hysterectomy can be done, which is when both the uterus and the cervix are removed. During the hysterectomy, pelvic and para-aortic lymph nodes are sometimes also removed to double-check if the cancer has spread. For stages 1B and 2A, the main treatment options are hysterectomy, radiotherapy, and chemotherapy. Radiotherapy is usually given as brachytherapy, which is when a dose of radiation is given locally to the cervix and the vagina. Chemotherapy is done with cisplatin, and fluorouracil can also be added. And sometimes radiation and chemotherapy are given at the same time, and this is called chemoradiation. For stages 2B through 4A, chemoradiation is the standard treatment, and a hysterectomy is not routinely performed. For stage 4B cervical cancer, palliative treatment with chemoradiation can be done to help relieve symptoms. To end on a bright note, remember that anti-HPV vaccination is available. In the United States, there's a vaccine called Gardasil 9, which targets 9 HPV strains, the 7 high-risk strains, 16, 18, 31, 33, 45, 52, and 58, as well as 2 other strains, 6 and 11, which are considered low risk for cervical cancer but can cause genital warts. HPV vaccination is recommended in both females and males, ideally between the ages of 11 and 12 years old, with a second dose given 6 to 12 months later. Alternatively, a 3-dose regimen can be used, where the second and third doses are given 2 and 6 months later. Males should be vaccinated because they may be asymptomatic carriers of a high-risk HPV strain that could cause cervical cancer in a female partner. Alternatively, catch-up vaccination can be done in individuals 13 to 26 years old who weren't vaccinated before. Alright, as a quick recap, cervical cancer is almost always caused by an HPV infection, most frequently with HPV strains 16 and 18. Screening for cervical cancer can be done with a Pap test every 3 years in females between the ages of 21 and 65. Abnormal Pap test results include the presence of atypical squamous cells, which can either be ASCUS or ASCH, or the presence of cervical squamous intraepithelial lesions, which can be either LSIL or HSIL. A reflex HPV test can be done at the same time as a Pap smear, which can come back positive or negative for HPV. Further management depends on the age of the individual. In females older than 25, a colposcopy should be done when the Pap test results are HSIL or ASCH, or for an ASCUS or LSIL result and a positive reflex HPV test. Depending on the result of the colposcopy, treatment options include observation for all types of cervical intraepithelial lesions, or a diagnostic excisional procedure, like loop electrosurgical excision procedure or cold knife conization for CIN2 and 3 lesions. In females between the ages of 21 and 24, more conservative options, like observation with Pap smears at 12 and 24 months, are preferred for ASCUS and LSIL lesions, and a colposcopy is done for HSIL and ASCH lesions. So, with appropriate screening, cervical intraepithelial neoplasia can be removed before it even becomes cancer. If it does go undetected, cervical cancer per se can present with vague symptoms like postcoital bleeding or irregular vaginal bleeding, and a colposcopy and sample biopsy should be done even if a lesion is not visible to the naked eye. Depending on the stage, cervical cancer can be treated with cold knife conization, a radical trachelectomy, a total hysterectomy, and chemoradiation. Thankfully, it can be prevented by vaccinating against high-risk HPV strains, either between the ages of 11 or 12, or catch-up vaccination between the ages of 13 and 26.
At the gynecology clinic, 28-year-old Luciana comes in because she was told that her Pap smear showed abnormal cervical cells. She is totally asymptomatic, and her previous Pap smear from 3 years ago was normal. Next, there's 36-year-old Cassie, who comes to the office after noticing vaginal bleeding after sexual intercourse. There's no associated pain with urinating, bloody urine, constipation, or pelvic pain. She admits that she's never done a Pap test in her life. Pelvic exam shows a friable mass growing on the cervix. On further history, both have been sexually active with multiple partners and use oral contraceptive pills as their method of contraception. Both Luciana and Cassie have different types of cervical pathologies. So, first let's talk physiology real quick. The cervical canal can be divided into 2 sections. The endocervix is closer to the uterus and is lined by columnar epithelial cells. The ectocervix is continuous with the vagina and it's lined by mature squamous epithelial cells. When the squamous epithelium of the ectocervix and the columnar epithelium of the endocervix meet, there's a line called the squamocolumnar junction. For your exams, it's necessary to remember that right where the two types of cells meet, there's the transformation zone, which is where cells multiply and transform into immature squamous epithelium through a process called metaplasia. Now, metaplasia is when a stimulus, usually a stressor, causes the stem cells in a region to differentiate into another type of cell that replaces the typical cell type in that region. For example, with Barrett's esophagus, chronic stomach acid irritation causes the normal stratified squamous cells that line the esophagus to get replaced by simple columnar cells. This is different from dysplasia, where fully differentiated cells turn into immature cells that have varying shape and nuclear morphology. Metaplasia is usually reversible if the stressor is removed, while only mild or moderate dysplasia is reversible. So, in the cervix, right at the basal layer of the transformation zone, is where dysplasia might start. This is also known as cervical intraepithelial neoplasia, or squamous epithelial lesion. In most cases, cervical intraepithelial neoplasia is linked to HPV infection, particularly high-risk strains like HPV 16, 18, 31, and 33. Don't confuse these with low-risk strains like HPV 6 and 11, which are responsible for warts. HPV viruses are DNA viruses that invade stratified squamous epithelial cells. They especially prefer immature squamous cells, so areas under constant friction or irritation with high cell turnover, like the vocal cords or the anus, are especially vulnerable. In the cervix, the virus inserts itself into the immature squamous cells of the transformation zone and then integrates its DNA into the host DNA. An important fact to note is what sets low and high-risk HPV strains apart, and that is the ability of the high-risk ones to make huge amounts of two proteins, E6 and E7, using the host DNA. These proteins are responsible for pushing mature squamous cells through the cell replication cycle by blocking the action of tumor suppressor genes. Specifically, remember that E6 inhibits P53, while E7 inhibits retinoblastoma tumor suppressor gene product, or PRB for short. The end result is uncontrolled replication of cervical epithelial cells which are resistant to apoptosis, or normal programmed cell death. Since HPV is a sexually transmitted infection, a high-yield fact to remember is that the number one risk factor for it is having multiple sexual partners and not using condoms. Other factors also increase the risk, like early age at first sexual intercourse, smoking, immunosuppression, like in HIV-infected individuals or transplant recipients, and low socioeconomic status. Now, in cervical intraepithelial neoplasia, dysplastic, HPV-infected epithelial cells are often described as koilocytes. These are immature squamous cells with dense, irregularly staining cytoplasm and perinuclear clearing, resembling a halo. And these cells pile up in the cervical epithelium, starting from the basal layer and moving upwards. So depending on how much of the epithelium is involved, thickness-wise, cervical epithelial neoplasia is divided into grades. Grade 1, or CIN1, affects the lower one-third of the epithelium. Grade 2, or CIN2, affects two-thirds. Grade 3, or CIN3, affects almost all of the epithelium. And finally, carcinoma in situ, or CIS, affects the entire thickness of the epithelium. Eventually, carcinoma in situ can progress to invasive cervical cancer, which is when cancerous cells break through the epithelial basement membrane and into the cervical stroma. These are most likely squamous cell carcinomas. The second most common type, also associated with HPV, is cervical adenocarcinoma, which involves the epithelial gland cells of the cervix. But either way, what you need to remember is that CIN classically progresses in a stepwise fashion, meaning from CIN1 to CIN2 to CIN3 to CIS, and eventually to invasive carcinoma. However, progression doesn't always occur, especially in low grades. In other words, the higher the grade, the more likely it is to progress to carcinoma, and the less likely it is to regress to normal. And this progression from HPV infection to cervical intraepithelial neoplasia to cancer is generally slow. meaning that it can take between 10 and 20 or even 30 years before invasive cervical cancer develops. So, given that HPV infection most commonly occurs in the early years of sexual activity, so let's say between the age of 20 and 30, an invasive cervical cancer typically presents in a middle-aged individual between the ages of 40 and 50. Now, in advanced cases, invasive cervical carcinoma can spread to neighboring tissues, like the uterus and the vagina. And that's why you need to remember that the majority of vaginal cancer is metastatic from the cervix. It can also pass through the pelvic wall and infect the bladder and rectum. A high-yield fact to note is that if it invades and blocks the ureters, it can cause hydronephrosis and eventually renal failure. That's because the kidney will continue to produce urine, but this urine cannot drain into the bladder. As a result, it builds up within the ureter and calyceal system, resulting in distension of the renal pelvis and kidney. Lastly, the cancer may also spread via the lymphatic and circulatory systems to other areas of the body like the liver and lungs. Cervical intraepithelial neoplasia, as well as cervical cancer, if not caught early, can progress without any symptoms for a long period of time. When symptoms appear, they typically include abnormal vaginal bleeding, especially after sexual intercourse, also known as postcoital bleeding. Vaginal discomfort and a foul-smelling vaginal discharge might also be present. In later stages, when the cancer has spread to the bladder, there may also be symptoms like urinary frequency, dysuria, and hematuria. If the cancer has spread to the rectum, there may be constipation. Flank pain that radiates to the groin can also be present, and, in your test, that's a clue to hydronephrosis. If there is metastasis to the lymph nodes, the individual might also experience pelvic pain. Diagnosis of an asymptomatic individual, or in other words, screening for surgical intraepithelial neoplasia and cervical cancer, is done with a pap smear, along with high-risk HPV DNA testing. Remember that cervical cancer is the most common gynecological cancer worldwide due to the lack of screening and availability of vaccines. But in high socioeconomic countries, like the US, it's less common, so endometrial cancer takes the highest spot. Now, during a pap smear, some cells from the transformation zone are collected with a brush, and then they're examined under a microscope for dysplasia. If the pap test comes back positive for dysplasia, it may be followed up with a colposcopy, which is when a magnifying device called a colposcope is used to get a zoomed-in view of the cervix and then obtain biopsies. In a symptomatic individual, diagnosis begins with a pelvic examination, where a lesion suggestive of cervical cancer, which may look like an ulceration or mass, might be identified. In some cases, the cervix might be enlarged and indurated with a smooth surface. A key word examiners like to use for that is barrel-shaped cervix. Diagnosis will be confirmed with a biopsy. Afterwards, a CT or MRI can be done to look for evidence of metastasis. Treatment of cervical intraepithelial neoplasia usually consists of local excision of the lesion with cryosurgery, where liquid nitrous oxide is used to freeze and kill abnormal cells, or conization, where the transformation zone and some or all of the endocervix is removed surgically. In contrast, treatment for cervical cancer is to surgically remove either just the tumor or also the uterus and associated lymph nodes. If the cancer is more advanced, radiation and chemotherapy may be done. To end on a bright note, remember that anti-HPV vaccination is available. In the United States, there's a vaccine which targets 9 HPV strains. The 7 high-risk strains, 16, 18, 31, 33, 45, 52, and 58, as well as 2 low-risk strains, 6 and 11. Alright, as a quick recap, cervical cancer starts as cervical intraepithelial neoplasia and develops very slowly. It can be classified in squamous cell carcinomas, which are the most common ones, and adenocarcinomas. Both are most often caused by a high-risk human papillomavirus infection. Many cases of cervical cancer can now be caught very early on by screening for precancerous lesions with a pap test. Precancerous lesions can be managed with cryosurgery or conization, whereas treatment for cervical cancer is surgical. Okay, back to both our cases. Both Luciana and Cassie have risk factors for cervical carcinogenesis, including multiple sexual partners and no use of condoms. Luciana was asymptomatic and came in with an abnormal Pap test result, after which she was referred for colposcopy and biopsy. The biopsy showed CIN2, which was removed with cryosurgery. In contrast, Cassie neglected her screening with Pap tests and had postcoital vaginal bleeding, as well as a vaginal mass found on pelvic exam, both of which point us towards invasive cervical cancer. This was confirmed with a biopsy of the mass. Imaging tests showed no metastasis, and she was referred for surgical removal of the uterus and associated lymph nodes.